Hear you if you are speaking.
We are live, please.
Live? Yes. Good morning, everyone. It gives me a great pleasure to welcome you all to this exciting webinar, The Next Gen, the Uveitis lecture competition organized by the Uveitis Society of India. Today's session is particularly special as we have with us the next generation of young and dynamic Uveitic specialists who will share the knowledge and insights through their own innovative and engaging style of teaching. It is wonderful to see such enthusiasm and creativity shaping the future of Uveitis care and education. I would like to extend my heartfelt gratitude to our esteemed panel of judges, Professor Amod Gupta, Professor Neri, Dr. Ina, and Dr. O. Chawla for taking the time to be with us today for guiding and inspiring our young presenters. I wish all the participants the very best for the presentations. I'm sure we are in for an enriching and enjoyable session. With that, now I hand over the proceedings to our Secretary, Dr. Patho Pratim Datta Majunda, and the Treasurer, Dr. Abhilasha Bharani, who will be moderating the today's session. Thank you once again. I look forward to an inspiring and engaging session of presentations.
A very good morning to all. It is my absolute pleasure and privilege to be a moderator for this NextGen USI meeting. I am honored and privileged to introduce our esteemed panelists. To begin, Professor Padma Shri Amod Gupta is one of India's most distinguished ophthalmologists and an internationally recognized expert in the field of uveitis and retinal diseases. He is the founder, professor, and former head of the Department of Ophthalmology at the PGI Chandigarh in India. Over the course of his illustrious career, he has been instrumental in establishing PGI as a center of excellence in ophthalmic education, research, and patient care. He is widely acclaimed for his pioneering work in ocular immunology, inflammatory eye diseases, and clinical research in uveitis. His contributions have not only advanced our understanding of complex inflammatory disorders, most notably ocular tuberculosis, but have also significantly improved patient outcomes. A teacher of teachers, Professor Gupta has trained and inspired generations of ophthalmologists, many of whom hold prominent positions across India and abroad. In recognition of his outstanding contributions to medicine and medical education, he has received numerous awards and honors, including prestigious national accolades. We are deeply privileged to have Professor Amod Gupta with us today, and we are very eager to learn from him.
Thank you.
Our next esteemed panelist is Professor Pier Giorgio Neri. He is the Director of Uveitis Service at Cleveland Clinic, Abu Dhabi. Professor Neri currently serves as a consultant ophthalmologist and head of the Uveitis Service at the Cleveland Clinic, Abu Dhabi. Throughout his career, Professor Neri has made outstanding contributions to the understanding and management of complex ocular inflammatory disorders. His research and clinical expertise encompass uveitis, ocular immunopathology, ocular imaging, and innovative therapeutic approaches, including biologic and targeted treatments for inflammatory eye diseases. Professor Neri is known for his dedication to global collaboration and education. We are truly honored to have Professor Neri with us today. We welcome you, sir. Our next esteemed panelist is Professor Rohan Chawla, a highly respected ophthalmologist, academician, and innovator who has made significant contributions in the field of vitreoretinal surgery and uveitis. Professor Chawla is currently the Professor of Ophthalmology at RP Center, AIIMS, New Delhi. It is one of India's premier institutions for ophthalmic education, research, and patient care. He has extensive expertise in retinal diseases, complex vitreoretinal surgeries, and diabetic retinopathy management, and is widely recognized for integrating advanced imaging and surgical technologies into clinical practice. Professor Chawla is known as a passionate teacher and mentor, actively training the next generation of ophthalmologists. Most welcome
you.
to you,
Thank
sir.
you. Thank you.
Dr. Reena is our another international panelist. It is a great honor to introduce her. She is a distinguished ophthalmologist, educator, and researcher, widely recognized for her expertise in uveitis. Dr. Reena currently serves as consultant ophthalmologist and lecturer at the Department of Ophthalmology, Faculty of Medicine in Jakarta. She plays a pivotal role in the uveitis and immunology service, where she is deeply involved in patient care, teaching, and research, including ocular tuberculosis. She has been instrumental in advancing the understanding and management of complex uveitic diseases in Indonesia and the broader Asia-Pacific region. She has published and presented extensively. As a dedicated teacher and mentor, Dr. Reena continues to inspire young ophthalmologists to pursue excellence in research and patient care. We are truly privileged to have you here with us today. Now, without much delay, I welcome all the participants who have chosen some very interesting and challenging topics, and we hope to be inspired by their presentations. The first presenter is Dr. Aditya Patil from Ojas Eye Hospital, Mumbai, followed by Dr. Anina, Dr. Anshukita, Dr. Anoop, Dr. Aarti from Chennai, Dr. Bhavik Panchal from Ahmedabad, Dr. Fatima Faima, and Dr. Femina Hashim. So we begin with the first presenter. The first topic is infectious versus non-infectious uveitis, a common quandary. Over to you, Dr. Aditya.
Good morning, ma'am. At the outset, I'll just share my presentation. The presentation is visible.
Yeah, Aditya, your time will start. I'll tell you about the timing, and we won't give any warning, anything. Just I'll say that your time is over. Okay.
Okay, sir. Okay, no problem.
Yeah. Okay, your time starts now.
Okay. Good morning, everyone. At the outset, I'd like to thank the Uveitis Society of India for this wonderful opportunity. And so I'll be speaking about infectious versus non-infectious uveitis, a common quandary. So why I chose this topic is because when we read in textbooks, everything looks absolutely straightforward. But in real world scenario, the practice of uveitis is much more different, because the central dogma of uveitis treatment is to rule out infection. Like how we have a central dogma in genetics, the central dogma of uveitis would be always to rule out infection, and always the lines between infectious versus non-infectious, they tend to blur out in the real world scenario. So we'll go stepwise, and we'll start with history taking in uveitis. Then we'll see external examination and clinical examination, followed by imaging biomarkers, then lab workup, molecular diagnostics, and case examples. Let's jump into history taking. Now, the start of uveitis care begins with elaborate history taking, and basic demographic factors like age, race, and gender are very important. This is where it starts, where you start differentiating infectious, non-infectious, starts right from the demographic factors and the history. So I've listed certain etiologies over here on the slide, which are common in different age groups in the infectious as well as the non-infectious categories. So in the young, in the infectious side, we have toxoplasmosis, toxocara, trematode, tuberculosis as well. So this is not an exhaustive list, and this is not a hard and fast rule, but it's just a rough guide as to what can be the possibilities across different ages. Specific is HLA-B27 among the middle-aged, and HZO among the older group, and weak lymphoma among the older group. So gender is also another important factor, because ankylosing spondylitis, which is one of the most common causes of acute non-granulomatous anterior uveitis, is more common in males, whereas lupus is common in females. Race is another important factor. As we see, birdshot color retinitis exclusively in Caucasians, and sarcoid is more common in the pigmented races, whereas Behçet's is common among the oriental races. Now, socioeconomic and environmental history is also very important, as cats are, associated with toxoplasma infection, and cattle and pigs with leptospirosis. So let's jump into external examination. Here we have clinical images. The man on the left hand side of the image, if you can see, he has a malar rash, which is characteristic of lupus. So the external examination itself gives us a wealth of information that helps us to work up the patient in the side of infectious versus non-infectious. On the left hand side, we have a lady who has these herpetic vesicles, which have scarred, and the herpes keratitis. Now, these two patients, we can see both of them have chronic VKH. On the left-hand side, we can see classical vitiligo. And on the right-hand side, this patient, when I put the indirect, I could see the red glow was very deep. Now, this sort of a red glow we often get in depigmented choroid with the sunset glow fundus. Just for comparison, I've also put an image of a normal red glow and what a red glow in a depigmented fundus looks like. This is just a soft marker towards VKH. Now, these images on the left-hand side, we have a dermatomal distribution, which points towards HZO. And on the right-hand side, we can see the heterochromia, which is very apparent in this patient, which points towards Fuchs. On this image, we can see the saddle nose deformity, which happens in Hansen's, syphilis, and GPA. On the right-hand side, we can see this patient who has a characteristic posture because of the spinal fusion that happens in ankylosing spondylitis, which is an HLA-B27 associated disease. We can see psoriatic rashes. So all of these things we can make out on clinical examination, external examination. This patient has secondary syphilis. We can see the papillomacular lesions on the arms and on the feet and hands. This patient has systemic sclerosis. We can see the tightening of the skin, and she had a mucopurulent conjunctivitis. This patient, she had this kind of a rash on the lower limbs. We can see the rash on the lower limbs, and she had a hypocoagulable state secondary to raised D-dimer levels. And this is post-resolution. So wealth of information can be gained from external examination. Let's jump right into clinical examination. We can see diffuse distribution of pigmented KPs, iris atrophic patches point towards a viral etiology, whereas anterior chamber acute fibrinous reaction points towards an HLA-B27, which is non-infectious. This is a comparison of the two. Both can be diagnosed with PCR. And when we have granulomatous KPs, Koppes nodules, Busaka's nodules, we can see that it's more common in granulomatous etiologies like TB sarcoid. We'll delve into that later in the presentation. This is a 9-year-old girl with bilateral chronic this anterior uveitis. It's a classical picture for JIA. This is a patient with Behçet's uveitis with oral ulcers and fern pattern of leakage and mobile hypopion. Another patient with sarcoid granulomas in the conjunctiva and bilateral hilar lymphadenopathy. Let's look at imaging. So for sake of time, this paper actually explores the differences between TB SLC whereas autoimmune SC. So tubercular serpiginous choroiditis appears to be have vitritis, maybe unilateral, bilateral, whereas autoimmune is usually always bilateral without vitritis. Most important in autoimmune, it involves the juxtapapillary area, whereas in TB, it spares the juxtapapillary area. These are my own patients where you can see in the right-hand side, this is a patient with autoimmune. On the left-hand side is the patient with TB. And on the OCT, we can make out the vitritis and the absence of vitritis. This is post-resolution. Then this another paper describes choroidal granulomas in TB versus sarcoid. TB granulomas tend to have an intense yellow color, whereas sarcoid granulomas have a dull color. Then sarcoid granulomas tend to be more numerous and bilateral, whereas TB granulomas are single and solitary and larger with disruption of the outer retinal layers. This is a case of retinal vasculitis. On the right-hand side, we can see TB retinal vasculitis with segmental involvement, whereas on the left, so on this side, we can see sarcoid retinal vasculitis with candle wax drippings. This paper shows classic rain cloud signs seen in candida and ophthalmitis. And they also describe two patterns, which is intraretinal pattern and a chorioretinal pattern. So these imaging biomarkers help us to understand infectious etiology. Now let's look at the non-infectious pre-retinal infiltrate seen in Behçet's uveitis. This is how it looks like. It's a focal thickening and hyperreflectivity of the inner retina with loss of retinal layers. We can. This is on one of our own patients who had this Behçet's uveitis with pre-retinal infiltrates. Post-resolution, there is a characteristic thinning of the RNFL. This is a case of syphilitic retinitis where we see a triangular patch of ground glass retinitis, and another variant is a placoid chorioretinitis with outer retinal changes. This is another paper that shows about the differences between toxo and viral retinitis. Toxoretinitis, often we have oval preretinal deposits and deposits on the posterior hyaloid, and the hyporeflectivity of the choroid is very important with choroidal thickening. This is a case of viral retinitis. Here we can see these features on the OCT are specific for viral retinitis, which is a mid-reflective intraretinal edema, and hyperreflective vertical strips are characteristic of viral. This is one of my own patients with toxoplasmic retinochoroiditis. We can see full thickness retinal opacification with choroidal hyporeflectivity. Then let's look into confocal imaging for distinguishing between non-infectious versus infectious. Infectious etiologies tend to present with dendritic, central globular with dendritic, and infiltrative variety of KPs, and non-infectious shows stippled globular or multiple globular. Let's look at lab workup. Lab workup, the basic uveitis panel that we do for all the patients includes complete hemogram, ESR, CRP, urine analysis, HIV, and TPHA. But to rule out infections, it's also important to do a serology for specific entities that we suspect. Serum procalcitonin can be done in bacterial etiologies, urine, blood culture, PCR, and NGS. That we'll see again in the future slides. So to rule in non-infectious etiologies, it's important to do ANA profiling, to look at systemic rheumatologic diseases, ANCA titers. Soluble interleukin receptor 2 can be done for the sarcoid cases and HLA typing. Additional tests include radiologic imaging and biopsy and histopathology wherever it's appropriate. Let's look at molecular diagnostics. But before we go into molecular diagnostics, it's important to understand that the gold standard for diagnosis of infectious uveitis is identification of the pathogen by routine microscopic staining and culture. So the PCR, real-time PCR, is one of the newer methods that gives quantitative estimation. It cannot detect organisms for which primers have not been provided. So we have to have a narrow differential diagnosis while ordering PCR. PCR is available for all of these entities. And metagenomics is the newer area, which refers to study of genetic material recovered from body fluids. And it helps us to identify unknown organisms as well. NGS is one of the types of metagenomic sequencing, which also called as deep sequencing, which is helpful for pathogen detection in case of culture negative and microscopy negative diseases. The biggest challenge with NGS is contamination. These are the two types of NGS that are employed. And this is a comparison between PCR and NGS. PCR helps in quantitative analysis, whereas NGS helps in identifying unknown microorganisms. Let's look at a case example. This is a 16-year-old boy who presented with complaints of blurring of vision in the left eye and history of travel and fever prior to this presentation. On the fundus examination, we can see there's retinal vasculitis in both eyes. And on closer
Time is up.
Okay, sir. So I'll just skip this and I'll just go to the conclusion. So in conclusion, always rule out infection, and a holistic and stepwise approach is very important. Elaborate history taking, meticulous clinical examination, appropriate imaging, lab tests, radiology, and molecular diagnostics can help us arrive at the diagnosis. Thank you.
Thank you for a very comprehensive presentation, Dr. Aditya. I now invite the judges, if you have any questions to ask. Audience is not allowed to ask questions. Any questions or comments from the judges or Dr. Padma?
Yeah, I think I was told by Partho that we could give feedback also. So you
Yes,
had
sir. Yes.
yeah. So Aditya, it was a remarkable, comprehensive coverage of the subject. And when you have a limited time span of just about 10 minutes, and you tend to rush through your slides, So sometimes we all wish to tell everything that we know about this subject. We all want to put all our material together. I used to do it very often long time back. When I used to make presentations, I wanted to inform the audiences everything that I knew about the subject. And in this kind of competitive presentations, I would have preferred that you limited yourself to key clues, or say like if you had talked about 10 clues or 15 clues, that this is how I differentiate. Telling from literature is fine, so long it supports your, hypothesis how to differentiate. But you try to cover the entire subject matter, entire book of uveitis you covered actually. So in 10 minutes, I think you have to rush through. So please take these as not as a criticism, but for future, maybe it will be helpful for you. Thank you.
Thank you, sir.
Sir, actually, we are very lucky to, the presenters are very lucky to get this kind of feedback so early in their career. It takes a long time and many mistakes in presentations to reach this. So I think it is a very good feedback what sir has given, and I'm sure all the participants will take it in a sporting way. Thank you. So our next presenter is Dr. Anina Anna Thomas. She is still doing her UVA and Medical Retina Fellowship at Narayan Nethralaya.
Abhilasha, can I just other judges have any point?
Yes,
Professor
yes,
Neri,
sure. Yeah, yes.
Professor Neri.
Yes, I mean, I wanted just to echo what Professor Amot said. In a presentation with a limited time, you have to guess before you craft it what is the take-home message that you want the people to get. So the take-home pairs are exactly what Professor Amot was saying. So the structure of the presentation should be, if you have 10 minutes, should be crafted for 7 to allow you to have this edge and try to help the people to understand what is very innovative and what is the known of the science behind that. So very well done. It was crafted very well, very comprehensive, but try to focus on what are the essential messages that you want to deliver to those who are listening to you. But very well done.
Thank you.
Professor Rohan Chawla, sir.
So sir has nicely summarized that what he has to do. So just to give him one or two indicators of some specific points which he could have included, like sir is saying. So you could have talked a little bit more specifically about things which we are worried too much, like infectious retinitis. So whenever you see retinitis, infection comes number one to your mind. So you could have talked specifically about that. Maybe something about endogenous endophthalmitis. So these are some specific infections which are very essential to be diagnosed early and managed in a different manner. So you could have just taken up these points, immunocompromised patients, some specific points about that. So something like this.
Sure.
Thank you.
Thank you. So can we go to the next presentation? Dr. Anina Thomas, I already introduced her. She is a fellow at Narayan Nethralaya. Please share your slide.
Thank you, ma'am. Hope I'm audible and my slides are visible.
Yes.
Thank you, ma'am, for the introduction. Without further ado, I'll begin. Just a second. Yes, so every disease leaves behind a molecular fingerprint. What if we could get a read on these fingerprints to profile, classify, and predict inflammation? Well, metabolomics will show us how. Good morning, I'm Anina. Allow me to take you on a journey through mapping metabolites in uveitis. So this is a roadmap of where we are headed. We will begin with what metabolomics is, how it fits into the omics landscape, what we currently know, and where the future may take us. Diving straight into the omics verse, These are the glossary of terms we will be dealing with today. Genomics refers to the genetic potential of the organism. Proteomics refers to the functional effectors of the cells. Transcriptomics, what seems to be happening inside. Phenotype is what we see. And finally, metabolomics, which is a real-time biochemical activity which is closest to the phenotype. This is a table which differentiates metabolomics from proteomics and genomics. Some of the differentiating features include the chemical variety, the high volatility, as well as the very high data complexity. Now, the best place to start, as we all know, is right at the very beginning. So let's go back to the very beginning. Coming to the evolution of metabolomics over the ages, its roots go back to the ancient times. And today we have entered the era of high-resolution mass spectrometry associated with artificial intelligence and integrated multiomics. Now, coming to metabolomics in human disease, studies have identified metabolite signatures predicting cardiovascular disease, liver disease, as well as in diabetes. Now, coming to metabolomics in ophthalmology, most of the studies have been done in the anterior segment, mostly studying dry eye, glaucoma, age-related macular degeneration, and diabetic retinopathy. Now, let's focus on uveitis. Most of the studies in uveitis have been done in the non-infectious uveitis category, mostly dealing with weak age, sarcoidosis, and Behçet's disease. Now, coming to our own experience of metabolomic analysis of intraocular fluid of patients with suspected bacterial endophthalmitis, this is what we found. Now, this was a study of 26 patients with 17 controls and 5 non-infectious uveitis patients. The endophthalmitis grading was done based on the visibility of the retinal vessels from 1 to 5. The fluids that we analyzed were tears, aqueous humor, and vitreous humor. The technique that we used was liquid chromatography with mass spectrometry, analyzed using a metabo-analyst. The workflow was after the systemic ocular and systemic examination, tears were collected of the patient suspected to have endophthalmitis using Schirmer strips, stored in an Eppendorf tube and stored at -80 degrees. It was then subjected to tear omic analysis. Now, what did we find? We found out key discriminatory metabolites in tears. The significant metabolites that we identified were methylenolenate, palmitoylamide, and myristoyl carnitine. We also noticed a correlation with the severity of the endophthalmitis. In the mild grade, we noticed that the metabolites were all near normal. But in the severe grade of endophthalmitis, we noticed a sharp decline in methylenolenate and palmitoylamide, along with a spike in myristoyl carnitine. Now, in the aqueous humor analysis, we noticed a decrease in phosphatidylglycerol and arachidonic acid, all related to the stability of the cell membrane. In the vitreous humor, we noticed findings similar to that of the aqueous humor, which showed a spike in the myristoyl oleate carnitine metabolite. Now, what is the clinical impact of this particular study? This was a non-invasive rapid diagnostic tool which helped us differentiate between bacterial endophthalmitis and non-infectious uveitis. This could help in early risk prediction and personalized therapy. What were the limitations of our study? The sample size was small and also the bacterial species could not be identified. To conclude, this is the first ocular fluid metabolomic study linking metabolites to disease severity. Methylenolenate, palmitoylamide, and myristoyl carnitine showed strong diagnostic potential. Now, what does this mean for us clinicians? How do we incorporate metabolomics into day-to-day practice? Allow me to explain with a case example. So this is a 36-year-old lady who presented to us with sudden painless progressive decrease in vision in the left eye. There was a history of fever associated with headache, myalgia 10 days ago. She was previously treated as a presumed neuroinfection, possibly rickettsia, treated with systemic antibiotics and steroids. In spite of that, she presented to us with worsening vision. On examination, right eye was normal, left eye 6/48 vision, intraocular pressure normal. Anterior segment showed anterior chamber reaction of 1+. Posterior segment examination showed an occlusive retinal vasculitis picture. This is what the fundus picture looked like. The OCT through the macula showed inner retinal bogginess with hyperreflective dots in the middle layers with SRF. Through the retinal infiltrate showed full thickness involvement, and the FFA showed block fluorescence along with localized staining and leaking of the vessels, particularly in the ITQ and STQ. So the patient had undergone extensive workup, already undergone extensive workup previously, but it did not offer any clues. We decided to go ahead with additional testing, including an autoimmune workup, which came back negative. So we were confused which direction to take. Could it be infective? Could it be autoimmune? So on probing further, we got a history that the patient had a rash during the febrile phase, which was pointing more towards infectious etiology. So we decided to deploy TROmics to help clinch the diagnosis. And what we found out was elevated levels of myristoyl carnitine, which was the same biomarker that we identified in our own study associated with bacterial endophthalmitis. Our diagnosis was further cemented by next generation sequencing from the aqueous humor, which detected Acinetobacter pittae, which is a gram-negative bacillus. And to the best of our knowledge, this is the first case of Acinetobacter pittae presenting with occlusive retinal vasculitis. Now, with the help of the infectious disease specialist, we put the patient on appropriate antibiotic therapy, including intravitreal injections, and the patient showed dramatic improvement from 636 vision to 69 vision over a period of 2 weeks with complete resolution of retinal infiltrates. Now, looking ahead, metabolomics can be applied to therapeutic monitoring, drug development, as well as point-of-care testing. And now the future is definitely fraught with challenges. The challenges of metabolomics that we need to tackle include standardization issues, data complexity, reproducibility, as well as the cost and accessibility. So as with the case that we showed previously, it shows that metabolomics does play a part in the day-to-day clinical decision-making process. So these are my acknowledgements. I thank my department, particularly my mentor, Dr. Padmamalini ma'am, for her continued guidance and support. So as we map metabolites today, we map the future of precision eye care. Thank you.
You are well ahead of time. 1 minute left. Thank you.
Thank you so much for a fantastic and eye-opener presentation. Can we have the first feedback from Professor Neri?
Sure. I mean, this is extremely, remarkable, I would say. Number one, you presented, a publication that you made already, and this is just the forefront of potential perspectives. And I would say that this can have remarkable repercussions in the daily practice. Regarding this, I wish to ask you a question. I mean, metabolomics has a cost, as you said, and certainly we need to benchmark this with other techniques. How would you advise this as a potential first-line approach in order to try to trim potential useless tests in the future for the decision-making in uveitis?
So there's definitely tremendous potential. I see tremendous potential of metabolomics in the front line. But as you said, definitely there's a lot of cost involved because the machines that we use, including the LC-MS, are indeed very costly. But per se, the sample, just taking the tear sample from using the Schirmer strips, that is definitely not costly at all. But the instrumentation, the analysis, yes, definitely it's costly.
Do you think that maybe in the future, focusing in centers and having a validation of how you carry the sample towards those centers that might be, the ones analyzing the different samples from other centers might be a potential solution? So which means having a networking strengthened the potentiality of this test?
Absolutely, sir. That's the way to go. We need a lot more studies on this. All the studies that have been done so far are all small cohort studies with small sample size. We need to validate the results first, and after that, definitely collaboration, working on the cost, cutting down the cost, so that this is a front line rather than a research intensive analysis.
Excellent. Thank you and congratulations.
Thank you, sir.
Professor Gupta, sir,
Yeah, it's it's a very nice presentation, and I think I'm hearing about metabolomics first presentation that I've heard in a lecture format. As a presenter, I would have focused more on explaining a little bit more about metabolites, how they're generated, and what is the genesis of a variety of diseases and there are thousands and thousands of disorders which will have metabolites in the blood, in the serum, or in the tears, as an aftermath of that. We needed to introduce a subject rather on a slow note for audience which is absolutely naive to the subject and not sensitized. And for a competitive section, your could have been more simplified. If you were presenting this work in a meeting of experts who have expertise in the metabolomics, I think you will score full marks. But in a meeting attended by clinicians, I think this has to be on a slower note with all the limitations. And as Dr. Neri pointed out, the research potential should have been highlighted more than the diagnostic potential, because it might be a useful technique 10 years, 15 years down the line. So you are preparing ground for adoption of this technique, cost notwithstanding, in the future. So you are making people future ready that these are the things to come. But for that, we need to understand a little more, about how these metabolites are generated in different infections. Is a Pseudomonas endophthalmitis the same thing as Acinetobacter, or is it fungal endophthalmitis producing the same kind of, does it have to do with low grade, more virulent, like TB or like syphilis? Would they behave exactly the same fashion, or and if they had associated comorbidities like HIV or diabetes or renal failure or transplants or any such thing. So these patients come with a lot of baggage. Our patients, they are not simple, that you can put into a simple algorithm that this metabolite gives you a clue. And I would like to ask you, based on this metabolite, I can't even remember the name of that, sorry. But would you be able to start the treatment without the help of any physical science or looking at the eye? Just have the lab do this metabolomics from the tear and immediately write a prescription. This is what it is. Okay. Otherwise, trying to differentiate between infectious and non-infectious, what Aditya told, mostly the clinical differentiations, which we have been banking upon. In this particular patient that you showed, very interesting that you came up with Acinetobacter retinitis. So I think if you had shown us the differential diagnosis of this patient, why you thought it was non-infectious, what were the non-infectious, what were the viruses, what were the other infectious microbes that you had in mind, and before you gave us the metabolite, which gave you the confidence to go ahead and treat with intravitreal antibiotics. So Yeah, in a nutshell, it should have been a far more simpler trying to explain, to a novice, to a naive audience, the concept behind all these, why there should be seen in the tears, why not in blood, why not from the where the infection is happening, and how does it come in the tears from something which is happening inside the eye, you know, infection, retinitis, how does the retinal infection uh, come out in the tears. And if before tears, they could be, if they're coming back into the blood or in serum, that might have been, still easier to follow. Why tears? Just because they're accessible? So it's a longish kind of comment, but I'm sorry. But your presentation style was excellent. I think I liked your style. I liked your content very much. For an expert meeting, it's outstanding. But for a lay audience, yeah, uh, it was a little too tough to grasp as you went along in your 9 minutes. You had enough time, actually. Thank you.
Thank you so much, sir. Thank you.
May I invite Dr. Reena for her comments, if any? Dr. Reena, are you well? Can
Yes.
you?
I would like very much to comment, Dr. Anina. I think you have a calm, well-structured, and visually elegant presentation. I like it very much. I know I can understand from Prof. Gupta point of view that you need to choose between making an approach from the scientific part, the metabolomic, or the clinical part. So because this is you need to understand your audience first. If your audience is a clinician, it might be nice to introduce starting from the clinical part because we know a disease takes three triangle branch: the host, the microbes, and also the environments. Maybe you can explain a bit, therefore, why you take this research approach. But I think this is a wonderful research, and also I really like how you presented this study. Actually, I think you are very kind to walk us through at the beginning about DNA transcriptomic and then also the metabolomic at the end. I think I would like to congratulate again. It is a very nice presentation.
Thank you,
Thank you.
Dr. Reena.
Thank
Dr. Rohan Chawla?
Yeah, again, a very nice presentation and very nicely presented. So just like the sir was saying, you could have just explained like how do you decide which metabolites you were analyzing, why some particular fatty acids or amino acids for a particular infection, and like you said, carnitine was increased. So just give some explanation if you would have thought of why do you think carnitine would increase in such a disease. So some of those basic explanations might have helped the next gen audience a bit more. Otherwise, a very nice presentation. Thank you.
Thank you, sir.
Thank you so much, Dr. Anina, for a wonderful presentation. We now invite the next participant, Dr. Anshukita. Dr. Anshukita is a consultant at Shankara Eye Hospital, Odisha.
Yes, ma'am.
Can we have your slides, please? And all the best.
Thank you, ma'am, for the kind introduction. I'd like to share my slide. Is it visible?
Yes, it's visible, and your time starts now.
Okay, so good morning, everyone. Today, my topic is polymerase chain reaction in uveitis. So, PCR is a molecular diagnostic tool used for amplification of the DNA of interest from a DNA template. It was first described by Carey Mullis in 1985, which fetched him a Nobel Prize in 1993. So this idea behind PCR came to Mullis in a very serendipitous way during a late night drive, which he has very well described in his manuscript, The Unusual Origin of the Polymerase Chain Reaction, which is actually a very good read. So coming to role of PCR in uveitis, the first documented use of PCR in uveitis goes back to 1990 when Brazin AP et al. Identified Toxoplasma gondii in a case of ocular toxoplasmosis in paraffin-embedded sections by the polymerase chain reaction. Use of PCR in uveitis now includes in many uveitic entities, including Mycobacterium tuberculosis, viral uveitis, endophthalmitis, and parasitic eye disease. And we have also been using it for identification of newer organisms as the causative agents of uveitic entities. Coming to types of PCR, we have conventional PCR, real-time, nested, broad-range, comprehensive, and multiplex PCR, which we will be discussing one by one. First, conventional PCR, which helps us in identification of single target pathogen. It requires multiple transfer of reagent samples and tubes, etc. So it's a little bit time-consuming procedure. Once PCR products is obtained, then gel electrophoresis is carried out for analysis. Next, the real-time PCR, which determines the level of disease burden by determining the pathogen load. It helps us determine whether the pathogen is a mere contaminant or does it have actually a causative role in the disease process. So in this real-time PCR, both the amplification as well as the detection occur in a single step. So it reduces the time required for us to carry out the PCR. And when used along with the qualitative PCR, it helps us identify as well as confirm the causative infectious agent. Coming to nested PCR, which is actually a variant of PCR, where the products of PCR undergo 2 successive rounds of amplification using 2 sets of primers. This decreases the chances of amplification of non-specific segments and increases the specificity of PCR. Coming to broad range PCR, which helps us in detection of bacterial or fungal genomic DNA in a given sample by using primers and probes targeting those regions in DNA that are conserved among most of the bacterial and fungal species, including 16S rDNA in bacteria and fungal 18S or 28S rDNA amplification. However, we are not able to identify the strain and the species using a broad range PCR. So coming to next, multiplex PCR, which is used in simultaneous identification of specific genomic DNA from different pathogens in a single closed tube reaction. So what we do here is we take multiple primer sets in a single PCR mixture to produce amplified products of different sizes specific for different DNA sequences. So what it does is it reduces the overall time taken and also the use of reagents. So a modern version of it is multiplex solid phase PCR strip kit, which consists of a 12-tube multiplex PCR strip coated with probes and primers that target DNA of 24 common pathogens, including Propionibacter acnes, Treponema pallidum, etc. Next is comprehensive PCR, which is actually a combination of multiplex PCR and real-time PCR. So first we do multiplexing to screen for infectious genomes like human herpes viruses, etc. And then we perform quantitative PCR to know the copy numbers in order to confirm its pathogenic role. So coming to applications of PCR in infectious uveitis, I would like to start with some case scenarios where a patient presented to us with a complaint of redness, pain, and blurring of vision in right eye. He was previously treated with oral steroid elsewhere. On slit lamp examination, he showed conjunctival congestion, granulomatous KP, sparse, AC cells of 3+, flare, and few anterior ridge cells. However, fundus was normal. He already had a Montouk of 15 mm positive previously, and we ordered quantiferon TB gold, which came out to be negative. HRCT also was within normal limits, and other tests were also negative. So we did an aqueous tap for him for PCR for Mycobacterium tuberculosis, which came positive for MPB64 gene of MTB, as shown here. So we started the patient on ATT, oral and topical steroid, and the patient performed well. So we know that ocular TB can be a diagnostic challenge sometimes, especially in the lack of evidence of any systemic involvement, and since non-feasibility of conventional methods is there to detect Mycobacterium TB in eye. So here PCR can be a valuable tool, especially as we saw that if the other tests like TST, GRA, or chest imaging are inconclusive. And it can also help us guide in starting ATT in few patients, like we saw in our case here. However, PCR results can be inconsistent due to variations in testing methods and due to lack of standardization across the laboratories in different reasons. So, a real-time or quantitative PCR can be used here to know the actual disease burden. So coming to case 2, where a 31-year-old male presented to us with blurring of vision in right eye. Anterior segment was with a normal limit. However, right eye showed anterior vitreous cells. Right eye fundus examination showed extensive necrotizing retinitis patches in the mid and extreme periphery. Left eye was normal. So again, here the AC tab for right eye showed positivity for varicella zoster virus in PCR with a high copy number. So we saw that how PCR was also important and instrumental in acute retinal necrosis. However, we should know that we should not wait for PCR results, and we must start with empirical treatment without any delay in all the ARN cases. PCR is also important in viral anterior uveitis to detect specific virus like HSV, VZV, CMV, and we can decide the treatment based on that. There are other uses of PCR as well, like it is very instrumental in identification of pathogen in cases of any suspected end of cases, and also to rule out cases of both, like whether it is infectious or non-infectious etiology in granulomatous uveitis. And in some cases we can also use PCR in clinching the diagnosis in conjunction with aqueous antibody levels. So what are the samples that we should take for PCR? So I have taken this picture from polymerase chain reaction CME series, which beautifully depicts the ocular tissues and samples that can be used for PCR. However, in infectious uveitis, we still stick mostly to AC tap and vitreous tap for our sample collection. And one most important thing is that sterility should be maintained during the entire process of sample collection. Coming to advantages of PCR, we know that it is highly sensitive, highly specific, and it gives us rapid results, which helps us in early diagnosis and early treatment starting. However, there are certain limitations of PCR as well, like false positive and negatives, which can occur in cases due to contamination during the sample collection, and if the PCR is not performed optimally. So clinical correlation is always a must. So what next if PCR fails? So we are now in the era of metagenomic next generation sequences, which is basically running all nucleic acid in a sample which may contain mixed population of microorganisms and assigning those to their reference genomes to understand which microbes are present and in what proportions. It has potential to detect 17,500 pathogens and has got ultra high sensitivity but low specificity. It also has got the it also has chances of false positive and false negatives. However, it has got a very high negative predictive value, which means a negative result in metagenomic NGS means a actual negative. So here I have compared the PCR with metagenomic NGS. We know that for PCR we need a target or a specific sequence for amplification, while metagenomic NGS can actually detect all the DNA sequences in a sample. So, however, metagenomics needs does a very extensive bioinformatic analysis, so it requires more time as compared to PCR, and also a larger sample is required as compared to PCR. And however, metagenomic NGS can be used to detect novel microorganisms also, but we cannot use PCR since we should have a known primer for the same. So we already talked about sensitivity and specificity. So the limitation with metagenomic NGS is that it detects all nucleic acid, making it difficult to distinguish a true pathogen causing the disease from the normal flora. So to conclude, let me say that PCR can be instrumental in rapid identification of pathogen, even at an early stage where the clinical picture is still confusing. However, I will conclude. However, the sample collection is a must. Like it should minimize the contamination, and the PCR should be performed in conjunction with other diagnostic methods not as sole diagnostic method in UV. Thank you all.
Thank you, Dr. Anshukita. Dr. Rohan Chawla, sir, your feedback first.
Nice presentation. You have nicely summarized about PCR, its how it is done, what are the different types of PCR, its utility, and also most importantly, its limitations. So definitely one needs to keep the limitations in mind, specifically the issues of contamination with in-house PCR and also the issues of standardization. And one should also always have the clinical picture in mind, because we need to understand that just identifying the DNA does not always mean that the active proliferating microorganism still exists there in the eye. There can be various reasons why you are just detecting the DNA itself. But yes, it has PCR has definitely helped us in many cases to make a diagnosis, like you have pointed out, especially in the viral retinitis cases. And I would say you've done a nice job for especially the youngsters to explain them about PCR. Thank you.
Thank you, sir.
Thank you, sir. Dr. Reena, comments from you? Any feedback on the presentation style?
Thank you, Dr. Anshukita. I think you present a very nice presentation about PCR, showing that you have logical flow from how simple the PCR until the recent one, the next gen sequencing. But I would like to, maybe for the audience from the clinical ophthalmologist, you should emphasize the clinical consequence earlier, and then put how PCR help us with its positive side and also negative side, the sensitivity and the specificity of each type of PCR. Maybe I will anchor the audience first with clinical problems. But overall, I think you have a good comprehension of the PCR technique, and it's really good for young ophthalmologists such as you are.
Thank you, Dr. Reena. Professor Neri, your comments and feedback, please.
So, Dr. Anshukita, you did a great job. It was extremely comprehensive. And once again, to be fair, extremely comprehensive means that you touched everything. And for the future, what I would do is just to let us follow the flow in a way that is structured as you did, but being less comprehensive. So the structure that has been presented had a lot of things that I found a little bit hard to follow. So I'm an ocular so I'm very familiar with this. But for those who are not familiar with, many of the details might have been lost given the very large amount of information that you gave. I really appreciated the historical part, because sometimes we do things and we don't understand where they came from. But since you're a very young and talented ophthalmologist for the future, you need to present a good pitch, meaning that you need to choose yourself for what you want to deliver, what the others should bring at home, and clarify why you have to make that decision, just to allow you to have a correct decision making. So try to let us understand why you want to have a nested PCR instead of a real-time PCR. And when you have to go forward and maybe go extra mile to convince your colleagues that this is the right thing to do. Because sometimes you may have, clashing opinions. And since you are one of the expert matter, you will tell them that's the right thing to do. But other than that, much appreciated. Very good job.
Thank you, sir. I'll take care of this from the next time.
Thank you. And Professor Gupta, final word from you.
No, there's no final word. I might seem like a villain of the piece in this meeting.
No, sir. Sorry to interrupt. I think all of us are very lucky, especially the next gen, to get this face-to-face feedback.
I like what Professor Neri mentioned just now. It's too comprehensive a subject to be covered in 10 minutes. I mean, if she had about an hour to speak about it, it would be perfect material for 1 hour lecture, not for 10 minutes lecture. The point, I think, is again that we have, like President Neri mentioned, we have too many details here, and we lose the focus. We are not even mentioning that when we say PCR, we mean pathogenic, pathogen-specific PCR, and how we need to think of a specific, organism which might be causing a uveitis, and do a test for that. And although she covered it in multiplex, and in her slide she did mention that these are the possible organisms for which you need to design either single PCR or multiplex PCR. And she also should have mentioned something about bioinformatics while covering the next-gen sequencing and how to interpret the data. And she did mention, of course, that the contamination is a major, environmental contamination is a major factor. How do we really interpret the bioinformatics information that is coming through that NGS, which are, of course, available now in India, come at a cost. And, so you could make it more thought out and go a little slow, go slow, so that let the audience comprehend what you're saying, kind of imbibe what you've said in one slide, and then go on to, and they are ready to go on to the next slide. So should have been a little slower. But since you had so much material on your slide, you wanted to go through them quickly. I think you lost the pitch there. So I would urge you to be a little more precise in what you want to say, and maybe make the material. It would have helped if you had shown us any results by clinical case, of how it helped. You should have talked about the sensitivity, how it changes from viruses to, say, tuberculosis, where it's varies from lab to lab, and it's maybe as low as 10 to 30%. So then there is no specific, PCRs available, and no standardization available. So that is a major drawback for these. When you do in-house probes, which are none of which is available, and those which are available like commercial, maybe you could have talked about Gene Expert and some of those multiplex, PCRs, which are targeting multiple genes of a single organism. So that, and the other is the resistance pattern, because you showed an ocular TB case. I thought you could have mentioned a little bit about how PCRs can be used in general in medicine for detecting quickly the MDR cases of tuberculosis. So it's a very vast subject, but you could have focused on very few aspects which are relevant to us as ophthalmologists. Thank you. But otherwise, it's a lot of material, a lot of good thought has gone into preparing it, and could have been a little slower for comprehension by one and all. You need to target the last man in the audience. I mean, the experts and people who do it every day, they would be able to quickly grasp what you're saying. But the last man in the audience should be your target. So you select your target audience. Okay, look, this is the guy I'm trying to target. I'm trying to teach. I'm trying to convey my information. I have a whole lot of information. And as far as the historical, I think what Dr. Neri mentioned, yes, it was a very, very good anecdote to start with. And you could also have mentioned that Kerry Mullis failed to publish his technique in, Science and Nature, where he felt crestfallen, heartbroken. And you could have told also that ever since this technique came in, the entire field of biology, the cell biology, has been revolutionized by this particular technique, which got published in some chemical journal. actually. Actor America, or I don't know exactly, don't recall. Thank you very much for the opportunity to make these comments.
Thank you, sir. I'll
Thank you,
keep
sir.
in mind your valuable feedbacks. Thanks a lot, sir.
Professor Neri, you have a point to make?
Just very, very quick. I think that when I met Professor Ahmad, I was a rookie, and it was many years ago. And I wish to deliver something to you guys, everyone, the mistake that I made. When you're in front of someone judging you or somebody that is a senior expert, you do the mistake that you want to impress. Do not do that. One thing that we forgot is that when you want to present something, number one, ask yourself what you want to deliver, as I told you already. But the other thing is that you have to enjoy, and you have to think on how to make your presentation enjoyable. And I echo what Professor Gupta said, is that try not to be overwhelming with the concepts, deliver what you believe is important to be delivered, and enjoy the presentation and make it enjoyable. That is for everyone, those who presented already and the one that are going to present.
Thank you so much. I'm actually enjoying all the feedbacks and learning so much from all the panelists. Thank you so much for being so honest and trying to help the next gen ophthalmologists. And going on to the next presentation. So Dr. Anup Kelgaonkar is young, but he's a very well-known name in uveitis. He's a consultant at LV Prasad Eye Institute, Bhubaneswar. And Dr. Anup will be speaking on genetics and uveitis. Over to you, Anup.
Your
Thanks,
time
thanks.
starts. Yeah, your time
Yes.
starts now.
Thank you, sir. So it's a marriage of two branches which are very big, and I do acknowledge, all the students and colleagues and the trainees that are looking at this presentation. I don't want to give it an idea that genetics is an answer to inflammation or uveitis in general, because because this inflammation is multifactorial and it is non-linear causality. And remember this, when we are dealing into this presentation, there would be many things to do, but it is many things and interactions of them. For the sake of this presentation and the project I'm working on, I have divided this into three groups, the involvement. First group is, of course, the autoimmune and autoinflammatory spectrum. We know this group, HLA-B27, NOD2 gene with Blau. The second is infections, and genetics could make it susceptible for the eye to either a atypical or a recurrent infection. And group three is very interesting group, which is IIDs or inherited retinal dystrophies. And I would like to go in a reverse sequence with describing group three first, because it's the least described and interesting group. Now, this group, I encounter patients which are of two types. First is, it is a case of inherited retinal dystrophy, but it is mimicking what we think is a uveitis. And second is, we are seeing true uveitis, but it is in a case of IRDs. Why this confusion? And I have been a victim to this confusion because of vitreous changes that we see in retinitis pigmentosa, cystoid macular edema that we see in retinal dystrophies, and other changes on angiography which mimic uveitis. Now, what's the way out is trying to differentiate with multimodal imaging, but also genetic testing. Changes like Stargardt's disease or ABCA4 associated, I have mistaken initially, and there are publications where SLC is a differential on fundus fluorescein angiography. Similarly, I spoke about intermediate uveitis mistakes earlier from early in career with retinitis pigmentosa and enhanced S cone-like disorders, which can mimic a chronic CME of uveitis. Now, the recent literature shows more and more other variants like PRPH2 retinopathy. We'll have a look at it through a case which can overlap inflammatory maculopathies. And that was the first group where it was not that was not uveitis, but clinical features mimicking the uveitis. Now, the second group I want to bring forward with all of us, this is a true uveitis, but at times this is preceding the inherited retinal dystrophy as the manifestation. The couple of diseases which are very well known in this category are Rosa syndrome, which is ALPK1 mutation that activates the pro-inflammatory pathway, and another one is autosomal dominant neovascular inflammatory vitreoretinopathy, also known as ADNIV. Through various mechanisms, what we see is IID might happen a couple of years later, but it's probably present now, and we see a true uveitis there. Usher syndrome is another one. This has highest autoimmune burden amongst all of these IIDs, with high number of antibodies in the blood. The trouble is photoreceptor degeneration, which is often light-induced, can mimic worsening of the uveitis. The uveitis in this syndrome is truly there. Now, enough of theory. I think let's go to a case. This is case 1. 9-year-old girl, band shepherd keratopathy, has seen vitreous wheals and vitreous membranes. And I think at this time, I was sold to the diagnosis of probably early onset sarcoid versus GIA, and the whole exome sequencing, because I thought it atypical, gave it to be a heterogeneous variant of ceroid lipofuscinosis neuronal type 8, which can have degenerative changes in the cornea and vitreous, thus mimicking this disorder. This makes us more and more careful about are we seeing neurodegenerative changes, or are we seeing a true uveitis. Now, second case, what OCT might look like a syphilis 1, and autofluorescence was a very wide hyper. Photopsy as was a feature. The profile was negative for TPHA VDRL. We kept on differential of autoimmune retinopathy. But since it was atypical, we also had an testing done for genetic, which revealed that there was a PRPH2 gene variation. And the theory reveals us that PRPH2 retinopathy can in fact mimic autoimmune retinopathy in early stages before it goes to the atrophic stage. And that's the group that I wanted to have an overview with, which the type A was it was IID but mimicking a uveitis, and the group B was it was preceding true uveitis preceding the IIDs. Then the next group, and this is a paradigm shift from what we're shifting to still in the presentation, is infections. Now, I can be subject to infections either by predispositions by various genetic predisposers, or recurrent retinitis. Say, for example, in toxoplasma retinochoroiditis, the last year there were various variations in genes identified, which imply lymphocyte maturation and interferon gamma responses against the toxoplasma, that could lead to recurrences. As well as that, TLR pathway polymorphisms can lead to pro-inflammatory responses in this disorder. So if we have early progression of AIDS, recurrent toxoplasma retinitis, the point here is there might be a genetic predisposition to it. This is not just that, there are other pathways which make an eye susceptible to, say, for example, IL-12 and interferon gamma axis makes eye susceptible to tuberculosis, and other cardinal status 1 gain of function can lead to fungal. So on and so forth. There are various the pathologies which can lead to genetic abnormalities, making eye predisposed to infections. Visit this case, a bilateral occlusive retinal vasculitis. We can see small to retinitis, and what we saw was on vitreous biopsy culture, there's an acrimonium species. Now, why should an eye get an acrimonium species bilaterally? No cardiac affection on the walls, nothing on the USG. And what I want to highlight on this slide is sometimes the mutation can be in T cell dysfunction in the local tissue, which cannot be got through the whole exome or the genomic sequences that we do. And another spectrum of diseases, if we see a bilateral CMV retinitis in non-HIV, especially in extreme subgroups, this could be associated with genetic associations like Viscott-Ullrich or diskeratosis congenita, which is often seen. They do have systemic manifestations. I would like to draw your attention to this very unique case, a small girl of hand-foot-mouth disease, and there was an epidemic going on in Bhubaneswar at this point. And what I was worried was after 3 months, it looked like retinitis pigmentosa. This was troubling me. There was inflammation in the beginning. Retinitis is there, occlusive retinal vasculitis is there, and what we saw in Alstrom syndrome, which can have rod and cone dystrophy. Now, probably the initial presentation was not Alstrom, but probably a double hit mechanism made it predisposed to that. The last group is which is probably most commonly known. I won't spend much time on this, but many monogenic and polygenic diseases can have autoinflammatory to autoimmune spectrum affection, and would probably deal with this case, which is not two. We sent this case for not two, multiple recurrences, and she had high triglycerides. We thought it because of tofacitinib, but the result shows that she had APOB mutation, which was reason for her hypercholesterolemia. She had blau, but also Hurler-Scheis, which was probably affecting the eye as well. In summary, inherited retinal dystrophies can mimic uveitis due to various features that overlap. Uveitis may precede or coexist with iitis, a true uveitis. Genetic factors can predispose an eye to a typical or recurrent infections. You can get in an exome, genome, or local cell mutation. Autoinflammatory, autoimmune spectrum, monogenic to polygenic associations are possible. Additional genetic association, as we saw APOP, which was causing dyslipidemia, can affect pharmacogenomics. And there are limitations where whole exome sequencing, whether to do WAS, GWAS, or local cell mutation studies is a problem. Thanks to my mentors and to my patients, without whom nothing is possible. Thank you.
Thank you, Dr. Anup. So going on to the panelists, I think first, can we have Dr. Neri? First feedback from you.
Well, first of all, I want to congratulate, very on time, very on point, very thorough in the description on how genetics can be the real deal. I have a question for you. How much you believe we are far away to potentially use this knowledge and have a pragmatic translation into the clinical practice? Because mainly now we are diagnosing, but we know that there are a lot of pharma companies that are extremely focused in trying to deliver potential treatments for genetic diseases. And I think that in uveitis, this is the real deal at the moment, because possibly in the future, we're not going to have just a molecular target trying to induce the immune tolerance, but we try to manipulate immune tolerance. How much you believe that we're far away? And the second thing is, when you have patients with pseudo-hereditary diseases, how would you like to have the interplay with the immune genetic knowledge to try to justify you to prove that that immune phenotype is the one that we're dealing with?
Thanks, Dr. Neri. The first part of your question, I'm as flummoxed as everyone probably in this field. And I made my rookie mistakes initially. I used to send this test, which is commercially available, whole exome sequencing. Now the costs are less, and only to find out that exome is only 1% of the genome. But what the whole exome offers us is a causality. But when we go to a genomic study, the Jiva study, there's no more causality, it's only association. And to add to this complexity is it might not be in the genome, it might be a dysfunction of a T cell in a local tissue. And how do you mix up all of these things, and where do you really collect the sample from? The simpler things may be viscotal rich and dyskeratosis congenita. You probably get the blood, send it for a whole exome, and the job is done. But something like CARD9 or STAT1 loss of function, it is extremely difficult to make a causality with them. So I think we are very much in early days of it. And the second thing now you brought about this about the pseudo IRDs or IRD uveitis overlap. I feel I could not present that today of being about, like, we have a genotyping of this case. Probably we have an immunotyping of this case. Look at which immunological markers are there in the eye and what are there in the blood, and then probably have a genotype, immunotype, and a phenotype correlation. But I believe we are still years away from all of this. Yeah.
Thank you. Thank you very much.
Thanks.
Thank you. Professor Gupta, your feedback, comments, questions?
Yeah, I think I didn't expect anything less from Anup than what he has made. And all the youngsters listening to this webinar should draw a lesson from the art of presentation. I think he came up tops in cool presentation. Absolutely, he's introducing a new subject, and very coolly and calmly he introduces the subject where there could be confusion. He gave those examples of pseudo and true inherited retinal dystrophies, IRDs, which may mimic or which may cause actual uveitis, and so also why some of these disorders may be recurrent, some of those infections may be recurrent, where there may be fault lines. And I think overall, I would consider this as a model presentation. And, given the time limits, he had organized very well thought out. Each slide had been worked out its finest details. I'm sure he spent hours and hours on preparing his material. Nothing extraneous, not a single word out of place, and not a slide not necessary for this kind of a presentation. So, outstanding presentation from my point of view, and absolutely a role model for presentation for the uveitis group. Thank you very much for allowing me to make this comment on Anup's presentations. Yeah, thank you.
Thank you, sir.
Thank you. I think, Anup, your day is made.
Yeah, yeah.
Yeah. But we'll have comments from Dr. Rohan Chawla, sir.
Yeah, excellent presentation, Dr. Anup. Very nicely explained. A lot of learning points for me as well. The point about inherited retinal dystrophies and uveitis, I think all of us have sometimes made a mistake of considering some of these diseases as uveitis and later on starting them on even steroids and immunosuppressants and later on realizing that we are probably unnecessarily treating these patients and it's actually a retinal dystrophy. So I think some of the clinical pointers you could for all the audience is that if it's something which is bilaterally symmetrical and has some of the arterial attenuation and some features despite the CME and some cells, one should always think of the inherited uveitis and the other inherited dystrophies. And the other thing which I learned from your presentation is that what you said about actually cases which were uveitis but later on turned out also to develop inherited dystrophies. That is something new for me and I think I would also have to read up for that. Thank you. Thank you so much.
Thank you. Thanks.
Thank you. Any comments from Dr. Reena?
Thank you. I think I have nothing but praise also for Dr. Anup presentation. I like it how he links everything all together. There's a lot of information on genetics, immunology, and clinical disease, and you were able to link everything. The structure was clear and systematic. Probably just to add the cherry on top, probably at the beginning, you can anchor the audience on how genetic understanding that you have given us can change management in the clinical setting. Congratulations once again.
Thanks. Thanks much.
Thank you. Thank you to all the panelists. Thank you, Anup. We'll move on to the next presentation. Our next presenter is Dr. Aarti. She'll be talking on demystifying CNVM in uveitis. Here, I'd like to point out Dr. Aarti's exemplary qualifications. She has done MS, DNB, FRCS, MRCS, FICO, and FAICO. So for a young ophthalmologist and being so qualified requires a lot of perseverance. She's working at Rajan Eye Care Hospital, Chennai. So over to you, Dr. Aarti. We are eager to listen to you.
Good morning, ma'am. Thank you for the kind introduction. I'm just sharing my slides. Are my slides visible?
Yes.
A very good morning to the esteemed panel. Today I will be talking on demystifying CNVM in uveitis. So these are my disclosures for today's presentation. Without much ado, I will dive into my presentation where I will be demystifying certain facts about inflammatory CNVM. So choroidal neovascular membrane is a relatively uncommon but vision-threatening complication of uveitis where there is a unique overlap of both ischemia and inflammation. So uveitic CNVM is the third most common cause of CNVM following age-related macular degeneration and high myopia. Why uveitic CNVM is more significant is this can occur in younger individuals and it can lead to significant visual impairment in the working population. So there are certain diagnostic and therapeutic challenges when it comes to dealing with the inflammatory CNVM, and I hope to summarize few important points in this 9-minute talk. So coming to the causes of inflammatory CNVM, we see that it is more commonly associated with posterior uveitis and panuveitis, a bit rarely with inflammatory intermediate uveitis and anterior uveitis. It occurs both with non-infectious and infectious uveitis with incidence of 2% in non-infectious uveitis. Among the non-infectious etiologies, multifocal choroiditis and punctate choroidopathy contribute to the major chunk of patients with uveitic CNVM. In infectious uveitis in the Indian population, toxoplasmosis is found to have a higher contribution and tuberculosis, whereas other infections, literature search revealed few isolated case reports. Now coming to the risk factors. Do all patients develop inflammatory CNVM? No. So certain predisposing factors like posterior uveitis with involvement of the Brooks membrane or choriocapillary ischemia, uncontrolled anterior chamber inflammation, and a disc involvement which predisposes to a peripapillary CNVM with bilateral uveitis are found to predispose to uveitic CNVM. Epiretinal neovascularization has also found to be a risk factor. And surprisingly, vitreous cells and vitreous hairs have not been associated as a risk factor. And again, a word on the genetic influence after Dr. Anoop's elaborate talk. Now coming to the pathophysiology, what happens in these settings? So first, inflammation leads to the release of inflammatory mediators, which degrades the extracellular matrix. It directly compromises the perfusion, causing retinochoroidal ischemia and VEGF release. So with this coupled with a direct damage to the RP Brooks membrane complex leads to the compromise of the outer blood retinal barrier, exposing the retinal structures to this inflammatory milieu. So I would like to use a simple animation to show what happens in this situation. So the neovascular fronts from the choroid glow beneath in the subretinal space, which increase in size and lead to the formation of subretinal fluid and sometimes subretinal hemorrhage, which later results in intraretinal fluid accumulation, loss of the foveal contour, which therefore results in defective vision in the patient. So how does a patient present to you once a patient develops inflammatory CNVM? So there may be a defective vision, or when the patient who had an improvement in vision may experience a drop in vision, or due to the CNVM, he may experience a central scotoma or distortion of vision, which is appreciated as bending of lines. Or there may also be a diffuse blurring of vision if it is coupled with the reactivation of uveitis. And all these symptoms may be unexplained by the ongoing inflammation or pre-existing uveitic lesions. So once a patient reports to me with these symptoms, I would like to do first measurement of visual acuity for distance and near and try to identify and understand the symptoms using an Amsler's chart, following which I would like to do a thorough anterior segment and a posterior segment examination. In the anterior segment examination, I would like to look for any presence of inflammation and other contributing factors which may present with similar symptoms like development of a posterior subcapsular cataract or a corneal compromise. In the fundus examination, we normally note that these uveitic lesions develop at the edge of previous lesions or associated with an atrophic scar. They may present subfoveally or parafoveally or in the peripapillary region, considering a previous disc involvement. They may be associated with intra or subretinal hemorrhages, subretinal fluids, and in the inactive stages, we may find a subretinal scar if the patient presents late to us. So there are few lesions like active choroiditis, serous detachments, subretinal granulomas, and hemorrhages, which can be confused for a CNVM. So what do we do? How do we differentiate? So this is when multimodal imaging comes into play. In multimodal imaging, I would like to use color fundus photograph, OCT, which is of course an indispensable tool in a UVA and a retina specialist armamentarium. This coupled with OCT angiography and the invasive fluorescein and indocyanine angiography may help us clinch and differentiate these lesions. These investigative modalities may also help us monitor the treatment and prognosticate the patient. So first, coming to color fundus photography, in this era of medico-legal cases, and where patients Google and read about their symptoms, a simple color fundus photograph may help us document these fundus findings and explain very clearly to the patient what is happening to them. It will also help us document the responses and detect regression and recurrence and progression. So in this patient who had a papillary CNVM, we can see that good resolution following injection anti-VEGF, the resolution of the findings. Coming to optical coherence tomography, so it is a non-invasive investigation which can be repeated every visit, which helps in diagnosing the patient, following up, assess them qualitatively and quantitatively, and assess the treatment response. So here I would like to take the example of Miss S, who was a 24-year-old female who was successfully treated for a tuberculous multifocal choroiditis and presented with defective vision in the left eye. So when we did an optical coherence tomography, we found the right eye was normal, but the left eye, there was the presence of the CNVM, which was above the RPE, with the presence of a subretinal fluid, intraretinal fluid, and we can see the choroidal backshadowing, which indicates that this is an active CNVM. This can be differentiated from an active choroiditis by the absence of an RPE elevation, and in those cases where a choroidal hypertransmissibility will be present rather than backshadowing. So active lesions have subretinal fluid, intraretinal fluid, and subretinal and hyperreflective material, and in rare cases, basilarity layer detachment and hard exudates. Once treated or once resolved, we can see that there is resolution of this fluid with formation of a scar and reduction in the size of CNVM. Chronic cases may have RPE atrophy and outer retinal tubulations. So I would like to emphasize on two signs, which are main signs, which can be seen, which is the pitchfork sign, where you can see hyperreflective projections, which extend into the inner retinal layers, known to be more commonly associated with inflammatory CNVM, though not pathognomonic. Another sign is the Sponge sign, which shows that there may be choroidal thickening when the presence of an active CNVM and inflammation, which resolves with treatment. So next, coming to optical coherence tomography angiography, it is a non-invasive methodology to visualize the network, the presence of the network in uveitic CNVM. It also helps us better understanding of the pathophysiology of the disease and follow-up. So in this patient, we can see the complete resolution of the neovascular network with treatment, and which corresponds to the resolution of fluid in the OCT image. Now, coming to the very important investigation, which is fundus fluorescein angiography, which is used to differentiate between active CNVM, choroiditis, and lesions. So in active CNVM, we find that in the early phase, there is early hyperfluorescence with late leakage with fuzzy margins. Active choroiditis may also present with early iso or hyperfluorescence with leakage and ill-defined margins, whereas a heel choroiditis will have early iso or hypofluorescence with staining under well-defined margins. Now we can see that the features of active CNVM and choroiditis appear to be the same. Now, how do we differentiate? So this is here I would like to tell the case of Mr. M, who is a 32-year-old male who has a previous history of posterior uveitis treated elsewhere. Now he came with complaints of metamorphopsia with a BCVA of 6.9. On examination, I found 2 lesions which were subretinal, but there was no evidence of any other inflammatory activity. So I suspected maybe was there a reactivation because I could not find any obvious fluid or hemorrhage. On doing a fluorescein angiogram, I found 2 hyperreflective lesions which corresponded to those yellow lesions with a margin of block fluorescence and diffuse hyperfluorescence which corresponded to window defects. So now, Here comes the importance of catching the early phase in FFA, where in the peak phase of FFA, we can see the neovascular networks which correspond to the classic CNVM are very well highlighted. So if this phase is missed, again, the diagnosis may be in doubt. So another important investigation which can help us to differentiate. So the OCT was done, which corresponded and showed two multifocal CNVM with two networks, one parafoveally and one subfoveally. So the next investigation, which can help us differentiate between an inflammatory lesion and an idiopathic inflammatory CNVM, is an indocyanine green angiography. Indocyanine green is very important and essential tool as it defines the choroidal lesions very clearly with an accurate assessment of the extent of the lesion. Here, the inflammatory CNVM lesions appear hyperfluorescent, whereas the inflammatory lesions
time is
appear
up.
hypofluorescent. I will just summarize my findings. So the high index of suspicion is required for the identifications of CNVM. Multimodal imaging and anti-VEGF with control of inflammation plays a mainstay. Thank you.
Thank you, Dr. Aarti, for the extensive talk. I think Professor Gupta has a paper on inflammatory CNVM where he had described the delay in diagnosis. But before we take comments from him, we'll ask Professor Neri to give his feedback comments on the presentation.
Well, number one, it was once again very comprehensive. And my suggestion next time is try to focus on essential, let's say, messages. Once again, I mean, you made me happy since, I mean, the first chapter that I wrote was with Professor Gupta's book, roughly, I would say 18 years ago, on choroidal neovascularization. It was the very first book chapter about inflammatory choroidal neovascularizations, and I spent 20 years of my career trying to study how to manage them. There is one thing that I would suggest is the missing point is not nowadays with multimodal imaging the real deal on how to diagnose it, because I can tell you that I would prefer to have an angio-CT instead of fluorescein angiography, because you can study the branching, so the morphology of the choroidal neovascularization instead of the leakage, which is one of the things that we couldn't do before this new tool was introduced. Number one is the reason why we may have the choroidal neovascularization, which is secondary to blood-brain barrier disruption. For example, this is one of the things that was not addressed, and the inflammation of the choroid, which is essential. Number two, one thing that I would have done is to point out on how to manage it, because there are plenty of publications by retina specialists, and here we are in Uveitis Society of India. You might have had a chance to tell what is the difference between a retina expert talking about uveitis and a uveitis specialist talking about retinal diseases, so posterior uveitis. So how do you treat the non-infectious uveitis? Is this just to simplistically inject an anti-VEGF in the eye? How would you tackle the systemic treatment? How would you adjust the systemic treatment? So those are opportunities for, I'm sure that you're going to talk about this many other times, on what makes the difference of the message that should be delivered to the audience. And as a young ophthalmologist and already accomplished so many things, this is a future opportunity that I'm sure that you're not going to miss.
Thank you, sir.
That's a very important feedback. Professor Gupta?
I think Dr. Neri has said all that had to be said about it's a very, very important and most neglected subject in the entire uveitis sessions that one comes across. And he's very rightly asked, how do you tell the difference? How do they behave differently? How is the etiopathogenesis different from the conventional choroidal neovascular membrane? And by the way, you should have used the most accepted terminology for it, which is the macular neovascularization rather than choroidal neovascular membrane. You know, that is the MNV is the most accepted and standardized terminology for this subject. But you have done very well, I would say. And as Dr. Neri pointed out very rightly, more than 10 years ago, when we first acquired our OCT angiography, the most impressive thing, what impressed me most was picking up these CNVMs or the MNVs, which were otherwise very difficult to tell the difference from a recurrence. When you come across a patient with posterior uveitis, very often you can't tell the patient's symptoms, like you wasted a slide on telling those symptoms and signs. They are indistinguishable, with the recurrence of posterior uveitis as well as development of macular new vessels. So you could have told us there and then, rather than go and do an Amsler chart. I don't know how many of you still do Amsler chart as a routine for your patients of uveitis or posterior uveitis, because this is not a common complication. And you would do straight away an OCT angiography, and without wasting time, you will like to inject an anti-VEGF. You could have also told us the response to anti-VEGF, and that it doesn't. Only very few injections need to be given for inflammatory choroidal neovascular membrane versus the age-related macular degeneration, and behaves more like the myopic choroidal neovascular membranes, which require only very few injections. You could have told about the toxoplasma scars, where they develop adjacent to the scar, and recurrence also happens there. You could have also told about the TB uveitis, posterior uveitis, being the commonest cause of these development of these new vessels. Because of the anti-VEGF, you could have theorized, you could have given hypothesis why it so common only in toxo in the scars, why it is extremely common in patients with punctate inner choroidopathy or PIC lesions, where it's almost universal, or how in the past we talked about the presumed ocular histoplasma syndrome, where they were diagnosed by then the location, the juxtapapillary, say in VKH disease, and versus the submacular new vessels. So there were so many aspects you could have touched about in this presentation, but overall, I think you had a little more material to show. And again, we are making the same point. Be concise, be very specific in your mind. And that comes when you spend a lot of time preparing. A lot of thought process goes into preparing your material. Each slide should come out from your heart, actually, what you want to say and what is the new thing you wish to convey to your audience. But anyway, thank you very much. I think we'd like to hear more about your personal experiences on the subject. But the choice is very good, I would say, which is very, very applicable to each one of the audience today. Each one needs to be aware of this phenomenon. Thank you.
Thank you, sir. Thank you for your feedback, sir.
Thank you, sir. Dr. Rohan Chawla, sir, this is your
Yeah,
subject.
so you've got a lot of points already from previous judges. So again, nice presentation, but just to improve your future presentations, again, just a few pointers. So you could have like shown two slides or simultaneously, where you could have shown how on an OCT what an active choroiditis looks like and what a CNVM developing in a choroiditis looks like. So you tried to make the differentiation between what is active choroiditis and what is CNVM. But if you show it simultaneously or just in subsequent slides, distant slides, then the point goes across more easily to the audience. And then talk a little more about Octa. Like Sir has also been saying that Octa is now the tool which has enabled us to diagnose these much early. So talk about how on Octa, how the segmentation should be done properly and what can be the pitfalls on that, how you might miss it if you don't segment it properly, and how you might again misdiagnose sometimes on Octa also. So if you show some of those cases, that also brings out the point better. And how after an anti-VEGF would the response be seen on these imaging modalities, how would it change on OCT and Octa, which would again tell you that now you can stop your injections. So these are some points you could have touched upon. Overall, thank you very much.
Thank you, sir. A few comments from Dr. Reena.
Yes, I won't add more because I think this is a very important and clinically relevant presentation. Maybe you should choose the topic you want to convey, even with all the suggestion and addition, you already ran out of time, so you have to make it concise, which message do you want to convey, and really convey that message across, maybe only 2 or 3. So this is really the art of not telling everything because there is a lot to tell, but you have to pick which one do you want to convey. I think that's it. It's a very good job. Thank you.
Thank you. Thank you, everyone. We move on to the next presentation by Dr. Bhavik Panchat. Dr. Bhavik is a senior consultant at ASG Eye Hospital, Ahmedabad. He will be talking to us on sarcoidosis, the master of disguise in uveitis. We can see your slides, Bhavik. You can start.
Yes, thank you so much. And can I proceed?
Yes, please.
Yeah, your time starts now.
Yes, good morning, everyone. What if the VKH case you treated today comes back years later as sarcoidosis? That's the reality of the disease, a true master of disguise in uveitis. Sarcoidosis challenges us because it never sticks to one script. It mimics, it coexists with other conditions, and it keeps evolving. It is a chronic, multisystemic granulomatous disorder in which there is an exaggerated cellular response to a variety of self or non-self antigens in a genetically predisposed individual. Today, I'm going to take you across a few interesting and fascinating scenarios where the diagnosis changed dramatically over time. Ocular involvement in sarcoidosis, when you speak about it, most common is dryness of eyes. Next is adnexal granulomas and intraocular inflammation. Today's presentation, we are going to focus mainly on the third component, that is intraocular inflammation. Uveitis is the most frequent form of intraocular inflammation, accounting for 20 to 30% of the patients during the course of the disease. Coincidentally, it is this same number, that is 20 to 30% of patients where uveitis is the presenting disease in sarcoidosis. When you look at the Western literature, bimodal distribution is common. There is no gender predilection, but after the age of 50, women are more involved. When you look at and compare the Indian scenario, the bimodal peak is absent. Posterior uveitis is more commoner than anterior uveitis. Conjunctile involvement is uncommon, and there is a female preponderance. Let's move ahead with the typical clinical features of anterior uveitis, intermediate uveitis, and posterior uveitis. What do we see here? This is a slit lamp image which shows hypopyon. So the clinical pearl here is hypopyon uveitis is extremely rare in sarcoidosis. Acute or chronic anterior uveitis both can present with sarcoidosis and almost always presents bilaterally. The most typical feature is granulomatous anterior uveitis with mutton fat KPs. Acute uveitis can have nodules, like as seen here, Coppé's and Busaka's nodules. Ironed out iris with loss of crypts suggests chronic granulomatous anterior uveitis. And delayed presentation or improper treatment can lead to severe anterior uveitis with complicated cataract. Important point here is iris nodules and posterior synechiae indicate moderate to severe inflammation. What we see here is a typical example of a dented pass. This is a pathognomic sign of ocular sarcoidosis. Moving on to intermediate uveitis, they can have snowball formation and snow banking as well. However, the hallmark is presence of minimal vitritis in ocular sarcoidosis. Moving to posterior uveitis, it can be either a unifocal or a solitary granuloma, like in this case, presence of a choroidal granuloma, or it can be multifocal, where there are more or less Dallen-Fuchs-like nodules or sarcoid spots which are present. The important differentiating point here, they're more in the inferior half compared to the superior half. We can also have optic nerve head granuloma, where neurosarcoidosis needs to be evaluated. They can also present it as multifocal choroiditis. The disease might be interesting. The history is even more interesting. The first description came in 1878 when Sir Jonathan Hutchinson reported policemen with strange purplish skin lesions. 20 years later, he described another patient, Mrs. Mortimer, and called it Mortimer's malady. Interesting point here, Sir Jonathan Hutchinson described his first case 4 years prior to even Cox postulated his tuberculosis hypothesis. Then came in 1889, the French dermatologist Ernest Besnier coined the term lupus pernio for the violaceous facial lesions we still recognize today. Then in 1899, we had Norwegian dermatologist Beck, who performed skin biopsies and described the peculiar granulomas, non-caseating ones, hence the term Beck's sarcoid. A lot of research continued, and in the early 90s, we had Carl Krebs, who described and identified the first bone lesions in sarcoidosis, and Darrier and Rousey combined to describe subcutaneous nodules. And in 1909, we had Christian Herford, who detailed uveitis fever linking sarcoidosis with the eye. In this interim period, X-rays were discovered, and we had bone conditions as well as multisystemic involvement, what was known. And finally, in 1914, Jorgen Schaumann synthesized these diverse manifestations into one disease entity, laying the foundation of modern understanding of sarcoidosis. So from scattered skin patches to a systemic immunologic disease, the story of sarcoidosis reflects medicine's journey of piecing together a true masquerader. Coming back to our features, we look at vasculitis and sarcoid-related uveitis. This is typically associated with non-obstructive vasculitis. However, ischemic retinal vasculitis is also reported. Vasculitis mainly involves mid-peripheral retinal veins. They can be either candle wax drippings or skip vasculitis, or they can be associated with inflammatory vein occlusions. You can have a combined form where you have candle wax drippings and skip vasculitis, or multiple forms of vasculitis with even presence of choroidal granulomas. Sarcoidosis has its own sets of complications. You can have uveitic cataract, you can have CME, retinal neovascularization with or without vitreous hemorrhage, epiretinal membrane formation, and peripapillary CNVM or a fibrosis, what was just described in the previous cases. But every case is not a textbook case. Let's look at some atypical presentations of sarcoidosis. It can present as Fuchs uveitis, like this case here, patient presented with multiple striate KPs all over the cornea and having iris nodules as well. Though this is a dilated picture, but the patient had nodules as well. Not always a scleritis be associated with RA or connective tissue disorders. Think of sarcoidosis, especially in a female patient presenting in her 5th decade. It can have Burchard-like chorioretinopathy. Let's look at a few interesting cases. This is a child, a 2-year-old kid who presented to us with sarcoid-like uveitis-like picture, had granulomatous uveitis, complicated cataract. On further follow-ups, also had arthritis and developed a rash as well. We did a pastoral lensectomy and vitrectomy for this patient. Intraoperative, we found multiple sarcoid-like granules, again more in the inferior half compared to superior half. This patient was eventually managed with the help of a pediatric rheumatologist, started on adalimumab, underwent genetic testing. We found NOT2 mutation and a diagnosis of Blau syndrome was made. Child is happy with contact lens right now and is aphakic. Case 2, when TB meets sarcoid, left eye patient presented with multiple neurosensory detachments. Right eye already had subvascular pigmentation, pointing more towards a tuberculous etiology, but picture was mixed. Manto was 5 millimeters, serum A is raised, started oral steroids, and after a week of ATT, eventually balancing immunosuppression versus infection control, this patient improved. So this was a mixture of both tuberculosis and sarcoidosis. Third interesting case, patient presented with sudden onset vision loss, had multiple neurosensory detachments, angiogram suggested of pinpoint hyperfluorescence suggestive of VKH, managed, and in follow-up, after a few years, we found that the resolution of VKH was different how we see with our patients. There were this reflectile dots which were present all over the fundus, such kind of a pattern which was present, and there was recurrence of uveitis. This patient was eventually treated with immunosuppressants and was thought of as sarcoidosis as a primary condition. Last but not the least, let us understand the relationship between ocular sarcoidosis and systemic involvement. Incidence of CNS involvement increased from 2% to 37% when fundus changes are present. However, certain authors have shown that there may not be a relation. but majority of the literature shows that there is a relation between ocular sarcoidosis and CNS sarcoidosis. Cranial neuropathy is the most frequent manifestation of neurosarcoidosis, and optic and the facial nerves are most commonly affected nerves. Coming to cardiac sarcoidosis, ocular sarcoidosis is a marker for vascular endothelial dysfunction and increased arterial rigidity, and choroidal involvement is associated with an increased risk of cardiac disease requiring intervention. So what do these cases teach us? That sarcoidosis is dynamic, systemic evaluation is critical, overlap is real, and follow-up matters. In uveitis, nothing is ever what it seems. So thank you so much for your for the engagement and for allowing us to present as well. Thank you so much. Dr. Bilasha, you're muted. You're muted, Dr. Bilasha.
Thank you for that. Thank you for your presentation, Bhavik. Dr. Rohan Chawla, sir, first comments from you.
Dr. Bhavik, thank you very much.
Thank you, Dr. Rohan.
But a little bit, I was a little lost in the presentation. I think this line of thought thought was a little lost there, because I think you started very nicely. You said a VKH and later it would probably turn out to be sarcoid, and I thought it would be very interesting to see that case, but you touched upon it very late and only in a small manner. And some of the cases you did show about what you thought as sarcoidosis, but you actually never talked about the international diagnostic criteria of sarcoidosis. So if one actually wants to make a diagnosis, do we fulfill these criteria? I know many ocular cases may not meet all the criteria, but then you would probably label it as forme fruste or something like sarcoidosis. So in all the cases you showed, I think you never tried to actually match it to the international criteria and actually established a definite diagnosis of sarcoidosis out there. And so I think that is what you should have talked about more, and so that we can definitely relate these cases to sarcoidosis, and where you felt that it is like sarcoidosis but not meeting the diagnostic criteria. So what were the features which were missing, or what were the features which made you think it is more on the lines of sarcoidosis? Then you talked about one case of Fuchs in which I think you showed those nodules, but I think those nodules are a feature known to be in Fuchs as well. So I would definitely not label it as sarcoidosis over there. So some of these cases I thought got mixed up. But yes, you did talk a lot about the overall manifestations of sarcoidosis in the eye. Thank you.
Thank you so much, Dr. Rohan. Yes. It was about managing time with the content as well. So that is where I could not put in the diagnostic criteria.
Professor Gupta?
Yeah, Bhavik, I thought you somewhere got lost. You could have started with the history first, rather than place it somewhere in the middle of your presentation. Because while historical facts were important, they did not, resonate with the title of your presentation, The Master of Disguise, because none of those masters actually disguised. They were describing newer aspects of sarcoidosis. So I would have, made a presentation in a kind of a linear fashion, starting with some basic historical facts which concern us. Because you talked about all about history of sarcoidosis even before discovery of AFB by Robert Koch. But you didn't tell us, if you were covering history, how was it diagnosed first time in the eye, which year, for instance, and how soon after, or how many years later before recognition as and how the TB has been, kind of related atypical mycobacteria or TB confused, in the pathogenicity of sarcoidosis, or some other antigens or foreign antigen which initiate this process. So if you wanted to say that, but clear examples, of which you did attempt to make one or two patients, you try to show how it might disguise, but if you want to title your presentation as Master of Disguise, I think you have to convince the audience that, well, it was disguised. So, isn't it? And secondly, you could have touched upon the need for referral to a rheumatologist or pulmonologist, and need for long-term treatment.
Immunosuppression treatment, yes.
Yeah, and sensitivity to corticosteroids. It's extremely sensitive. The role of fluorescein angiography in this particular instance, when you're dealing with sarcoid vasculitis, and trying to differentiate between TB vasculitis and sarcoid vasculitis, and the activity, because that's the most impressive tool to tell about the response to treatment with corticosteroids. If you stop seeing leakage in these patients, that means your patient is responding very well. So some of those factors, there is so much to talk about in sarcoid, and you could not, time constraints couldn't, why they had to change the criteria. If you had to talk 10 minutes on why there was a need for criteria and why they had to kind of dilute those criteria later on and modify those criteria, and how we differ from the criteria given by the rheumatologists and other physicians. Where are the differences? Because they don't pay much attention to ocular involvement as a mark of severity. But you rightly touched upon neurosarcoidosis, and you could have talked about the involvement of meninges in sarcoidosis, how they may present to you with facial palsy and stuff like that. So it's a wide spectrum of disease, and you try to cover a lot, but appreciable. You were pretty cool. You were not rushing through your material. So that was something very appreciable in your slides. And since we have too many slides to show, I would pick only those which are absolutely clear, and only those which don't have to crowd the slides with too many pictures. Just keep one or two which make your point, and that would make it an outstanding. Anyway, very nicely covered subject. Thank you very much.
Thank you so much. Yes.
Thank you. Professor Neri, your comments, please.
Yeah, so Dr. Panchal, I want to congratulate you for one thing, is that the flow was impeccable.
Thank you.
So you are a talented presenter. The point that Professor Gupta made is absolutely crucial for your future. So the great thing is that you delivered a good presentation. The content was good because of your presentation skills. The structure of the presentation should have been improved as per what has been said already.
Yeah.
And the thing is that I do consider, for example, the sarcoidosis the greatest mimicry non-infectious uveitis. It can present in so many variable immune phenotypes. And when you have to present something that is so complicated and presenting multiple and different potential immune phenotypes, you should help us on how to get out the wilderness of this, which is not very clear in your presentation. So that is exactly the role. So when you have to present something that has so many variables, my suggestion is to point out on how to help the people listening to you to get out these problems.
Yeah.
So starting from when the first description happened, how we need to navigate through the different immune phenotypes. And for example, one thing that is extremely important, what we have to give to patients.
Yeah. True.
Because when we have a multiple different potential treatments, which is the one that you want to start with, and what are the potential issues that we may encounter along the way? Other than that, great job.
Thank you. The dilemma here was about what to include and what not to include with such a vast topic. I take your points in a very positive manner. Thank you so much.
Thank you, Bhavik, and thank you to all the panelists for such honest feedback. And I now invite Dr. Fatima Faima for her presentation. And she is still a fellow at Shankar Nethralaya, Chennai. She'll be talking about humanized computer versus computerized human, the AI's part in uveitis, which is a burning topic now. And we are eager to listen to Dr. Fatima.
Thank you, ma'am.
Your time starts now.
Good afternoon, everyone. I will be walking you through the insights of humanized computer versus computerized human, the artificial intelligence part in uveitis. So the goal of this presentation is to explore how artificial intelligence complements this complex disease of uveitis. The integration of artificial intelligence in ophthalmology has revolutionized our field in terms of diabetic retinopathy screening, glaucoma detection, or AMD monitoring. So, as practicing clinicians, we no more have doubt on how this artificial intelligence is going to transform our practice because we already know the answer for that. But it is more about how we are going to navigate the delicate balance between artificial intelligence and human expertise. So, what is the exact need for artificial intelligence in uveitis? Uveitis is one specialty which has got diverse etiologies, and it has wide variations in epidemiological background, and there is a greater dependence on multimodal imaging, but there is also a global disparity in access to uveitis specialists, as well as there is always an inter-observer variability. So all these features makes uveitis a true challenge and a new artificial intelligence frontier. It offers us a novel approach, shifting from a mere descriptive evaluation of cases to a more precise pattern recognition and prediction. So there is a lot of work that has been going on in this use of artificial intelligence in uveitis. I will be walking you through some of the examples of the applications of artificial intelligence in our specialty in terms of diagnosis, imaging, as well as patient education. So before going on with the topic proper of use of machine learning in uveitis diagnosis, let's see what exactly is this terminology of machine learning. It's nothing but a data set which is composed of the patient's details is fed into a system. The machine will analyze this data with use of certain patterns inside the data, and it will create algorithms. So with these algorithms, when you incorporate some new unseen data into the system, it will generalize this algorithm and will present you with the prediction of that unseen data. And this is done without any external step-by-step instructions. So in simpler terms, machine learning is nothing but the computer learns from the experience, just like us clinicians, but it does that in a way faster rate with mathematical precision. So coming to the, now we will see about the machine learning in case of uveitis diagnosis. The classification of uveitis based on the anatomical and etiological entities have been provided by the Sun Group decades back. But in this era of artificial intelligence, the Sun Group has used machine learning algorithms in order to create a classification criteria for 25 specific uveitis entities. And by this criteria, it has minimized the misclassification rates. So this approach also performs sufficiently well in case of clinical and translational research. And another algorithm devised based on the Bayesian belief network by Gonzalez Lopez et al. Has shown that the predictions of probable diagnosis by the machine match that of the senior clinician's diagnosis in 80% of cases, which is quite a number. And similar reports have also been provided by another study by Jamilox et al. So all these examples demonstrates how machine learning can support expert judgment. Let's now see about the role of artificial intelligence in uveitis imaging. So in case of anterior chamber cell analysis, worldwide a followed system is the Sun Working Group system of categorization of the anterior chamber cells with various grades. Now, with the advent of artificial intelligence, we can actually very safely keep this aside because AI-driven OCT algorithms have actually come up to categorize these cells in a more objective manner rather than a subjective analysis. And hence, this will help in better monitoring of the patients as well as it will help in reducing the inter-observer variability. Similarly, in case of vitreous haze analysis, automated systems have come up with a rapid, standardized, and reproducible analysis of vitreous haze. And on analysis, it was found that it was within one level of agreement to expert reader grades. And this could prove useful in clinical as well as ophthalmic monitoring of uveitis patients. And in a recent study by Futera et al., the automated analysis of retinal vascular parameters was compared in 3 groups of, namely the ocular tuberculosis cases which were confirmed from that of quantiferon TB positive uveitis without another identifiable cause, and a control group which was ocular toxoplasmosis. And it was found that venous tortuosity was one of the important diagnostic parameters, and it was lowered in confirmed ocular TB cases. And this automated analysis had a moderate to good performance. And they also found that there was normalization of this venous tortuosity upon uveitis resolution. And this automated analysis provides a paradigm shift in the TB, especially in case of TB endemic resource-limited regions, for better rapid triaging as well as referral with timely intervention. In case of artificial intelligence in fluorescent angiography analysis, transformer-based models have actually have been trained based on this fluorescent angiography images and into training and validation set. So, and then this was actually tested in comparison with the senior uveitis experts diagnosis, and it was found to have comparable results in terms of optic disc hyperfluorescence, vascular leakage, capillary leakage, and macular edema. So all these imaging revolutions have enabled a more consistent assessment of these cases, and it also provides a better understanding of the disease process. So the last example I would like to cite is about the role of uveitis in case of patient education. So in everyday clinicians practice, everyone would have faced patients who come to us with Google diagnosis. But nowadays, in this era of artificial intelligence, there is no more of just Googling. They analyze the disease with the help of certain AI imagings like ChatGPT and all. So in order to analyze what is the quality of the material that is being provided by these LLMs, which is in turn going to affect the understanding of the patient, Kianan et al. Study on comparison of this Google's Bard and OpenAI's ChatGPT has showed that ChatGPT was able to generate content and it was able to rewrite the patient information in an increasingly readable manner. So this in turn will influence the patient's understanding of the disease when provided in a right manner. So although there has been developments in AI in uveitis, there are still certain challenges that remain. One is there is a lower availability of this heterogeneous data, which in turn will influence the external validation, and it will lack generalizability to the entire population. And this development of AI-related models requires data, which is actually vast amounts, and this in turn will have concerns over the data privacy. So the future directions would be, there has already been several studies which are coming up with integration of multicentric data in order to have a better generalizability of the study. And in integration of these AI developed models in teleophthalmology will help in better diagnosis and it will also help in diagnosing the patients at a faster rate, and also helps in monitoring of the patients better. And rather than creating a model with a single parameter, creation of models with integration of varied parameters like clinical presentation, the features, and the imaging will provide a more holistic approach to the management. And uveitis is one condition which is not a single point management. It is actually one thing which is actually going to have a longer follow-up pattern. So longitudinal model development will prove beneficial in that aspect. So to conclude, AI-devised models transforms the way we manage uveitis. It helps in earlier disease detection, more accurate metrics-based monitoring, and it also helps in personalizing the treatment for each patient. So thus, at the end of the day, it's neither a humanist computer nor a computerized human that is going to excel. It is actually the strength that lies in collaboration between the clinician's expertise and computer's precision, which helps in better patient care. Thank you.
Thank you, Fatima, for choosing a very important topic and giving a very good conclusion to it. May I request Dr. Reena to give her comments? We can have a longer discussion on this topic. Dr. Reena is actually not keeping well. Are you there? Okay, Professor Neri, comments from you?
Sure. Congratulations. I mean, you were perfect, impeccable in timely fashion, and the presentation workflow was very, very, very smooth. I do really appreciate also the analysis that you made regarding also medical legal standpoints, because, for example, ChatGPT storage of the sensitive data might be a problem. And of course, nowadays there are many regulatories telling on how to try to tackle the problem. And of course, there are many, many other platforms that are, potentially involved into this conversation. And I like also the conclusion telling that deep machine learning is one of the tools that we need to take as a potential, let's say, booster of our knowledge and try to leverage that, not replacing us, but having the opportunity to use this tool to have a faster and more accurate, let's say, diagnosis or potential solution. One thing that I wish to ask you, since I guess that you're a passionate of deep machine learning, is how do you believe that future mathematical algorithm will change the potential approach? Because those are important aspects. Because we know that ChatGPT has problems. For example, there is a game that is called Wordle that is extremely easy, and if I challenge the machine to pick 5 letter words and guess which one is, I win 100% of time. Because if it fails 1, 2, 3 attempts, enters in a loop and you don't have the answer. So at this point, it's true that for simple questions, you may guess which kind of solution is. But when you give complex images, for example, to understand whether you're in front of, I don't know, toxretinitis instead of VZV retinitis, the machine goes into a loop that doesn't get out and doesn't give you the answer. How much do you believe that we are far from, and how do you suggest to tackle this problem to give us the tools that we need to run diagnosis and find solutions?
In order to prevent this kind of confusions of wrong diagnosis, it is better to inculcate the data. That initial training of that automated models is actually very, very essential, because how quality the data set that is being provided for training of these models is actually of utmost important. Because so that's why there should be a multi-centric and different population based imaging that should be inculcated into these models for training purposes, because that's the basic step, I think.
That's great. So one thing that is ethical, and I wish just to tackle this as well, is it's important to tell that open source, artificial intelligence platforms such as ChatGPT and even ChatGPT 4.0 has the opportunity to create your body, meaning that you yourself train your artificial intelligence, and this is a sort of private cloud. So do you advocate to have a networking and create a platform maybe for professionals to try to have a very high quality skimmed data to train the machine to have the optimal, let's say, normative database that creates the conditions to have a high quality service for your artificial intelligence tool?
Yeah, that will be even more better, and it will be even more professionalized for the individuals which are using that particular data.
Thank you. Congratulations. I really enjoyed it.
Thank you, sir.
Thank you. Dr. Rohan Chawla?
Yeah, thank you. Nice presentation. I think it's a new frontier for all of us. All of us have started just dabbling with this field. So you've nicely talked about the common things which one needs to know before you start using AI in your field. And I think a little bit you could have touched a little bit more about what is the difference between simple machine learning and what is the difference between a deep learning and what actually AI is, because many times we just call everything as AI, whereas it is just simple machine learning. So there is a slight difference there which you could have talked about more. And definitely you have talked about some of the recent studies in uveitis. That's good, but as you mentioned, these are very initial studies and one needs to have much more good quality data and much more trained data sets with larger number of patients, which would probably provide us information, more clinically useful information in future. And your conclusion was nice, that there is no distinction between a humanized computer or a computerized human. Probably it is going to be a co-pilot sort of situation, and where this computer is going to help us. And one line I like from another conference which I heard, where again there was this talk that actually how what AI is going to be in the future, and should we adopt it, or will AI replace doctors and all. So someone made a comment that in future, yeah, AI may not replace doctors, but it may replace doctors who do not go ahead with AI. So unless you also adopt this new technology, you might be outdated. But it's not that the AI is totally going to eliminate your clinical acumen and your clinical decisions. So all these things are there, and like it's a new frontier. But yes, you have very nicely summarized it in your presentation. Thank you.
Thank you, sir.
Thank you. Professor Gupta, sir, your perspective, and we'd also like to know your take on the ethics about using AI, what Professor Neri was also trying to say.
Well, first thing first, coming from Sankar Netralaya, I didn't expect anything different from Dr. Fatima talking about development of a tool. Now, as you might know, we have an audience of, general uveitis experts or ophthalmologists, large majority of whom will not be developers of a tool. Okay, I don't think in individual capacity we'll be able to generate a tool which will get validated or get FDA approved or whatever your European Union approved, those kind of. And you might be surprised to know that contrary to nearly 900 plus tools that have been FDA approved in the US, none of the ophthalmic tools have yet to find approval of the FDA. So whatever is being done is on an experimental basis. And as far as the Doug Jabs, example you quoted, because we participated by contributing almost 250 patients to his entire data pool, so I know a little bit about how he went on. So he collected disease-wise. So we diagnosed those diseases, and we filled in some of the granular data sets, into the online form, and submitted images. So he pulled together, from all over and analyzed using artificial intelligence. So he just wanted to come out with certain criteria based on the inputs from 200, 250 in each category of the uveitic entity, and he covered almost like practically all, and gave the simplest criteria to be included as diagnostic criteria. Having said that most of us are not going to be developing a system or incorporating spectral domain OCT, a tool of our development into the commercially available fundus cameras or angiography cameras or OCT angiography or anterior segment cameras or OCTs for capturing all those very nice papers which you cited. Okay, so what I see immediate application, and I didn't find any mention of that, is adoption of AI in our daily practice even now. And for that, I think for an audience of this kind, I would have preferred that. And like comparing AI, and I think if Rupesh Agarwal, I don't see here, he's done a lot of work in this field. When you have prompted the AI, okay, and mostly the large language, models, LLMs or ChatGPT is one generic, you could say, or a specific example of that, large language models, where they compared, is AI, ChatGPT, say, is able to give the same differential diagnosis as a set of uveitis experts. For doing those kind of studies, which are immediately applicable in our day-to-day practice. So one needs to be able to generate those prompts. So when I see a patient with acute uveitis, what are those prompts or minimum or the optimal number of prompts in our description of anterior uveitis or intermediate uveitis, posterior uveitis, a variety of posterior uveitis, which will fetch us a differential diagnosis. Okay, so I think that is immediately applicable, and then you need to go, because the major problem with using AI tools, applying these AI tools in the present scenario and is hallucination. Even if you heard the discussion between the Nobel laureates 2025 roundtable discussion, they were all, including the guy who from the University of Toronto, who was the main guy who developed this artificial intelligence tools. And they said, well, this hallucinates, is given to hallucination almost 10% of the times. It will not give you the right information. So this needs to be verified by the physician before you are applying that information gathered from these kind of tools. So you would, at this stage of development, you would need these to be verified by physical exam. And you can't say that, well, you take a SDOCT and it will give you a diagnosis. No way. You take a fundus picture and no way it will tell you whether it's TB or sarcoid or what. So unless we have the people who are research institution, like one of yours is a leading institution in this discipline of creating tools and kind of algorithms, basically, which will be used by most of us in future. So it's a great attempt, but it could have been more focused on, and you could have told in the beginning what is the objective of your talk, what you want to convey to the audience, whether you are introducing AI role, what has been the research as a research tool, people are developing various tools, various algorithms, or is it the application which is more, majority of the people should be using, if they are not already using AI in the day-to-day practice to get it quick, in the clinic, generating summaries, like you mentioned about counseling the patients, or patient-friendly readouts about particular disease. When you want to say, well, this is a hand-foot-mouth disease, you might be able to give them a handout. What are the precautions, or if it's a sarcoid or TB, or so automatically it will generate you not only a summary but also a patient-friendly readout to be consumed at home in the comfort of home setting. So some of those tools are already being used in the clinics worldwide, which are applications of AI rather than development of the tools. But if your focus was development, I think you very nice lecture that way, talking to us about development of algorithms in these artificial intelligence. Thank you for the opportunity. Yeah.
Thank you, sir. Thank you for the feedback.
Thank you, Fatima. We'll go on to the last presenter of the day. Dr. Fahima has been waiting patiently. She is a consultant at Chaitanya Eye Hospital and Research Institute, Trivandrum, and she'll be talking to us about nano-based drug delivery system for the treatment of non-infectious uveitis. Over to you, Dr. Fahima.
Thank you, ma'am. Is the screen visible, ma'am?
Yes, yes.
So a very good afternoon, one and all. I'll be talking about the nano-based drug delivery system in the treatment of non-infectious uveitis. Before going to the actual topic, let me discuss you something. Imagine you are trying to deliver a message to a castle that is surrounded by guards and gates. That is what exactly scientists face when they are trying to deliver a therapeutic molecule into the eye. from the tear film that washes the drugs away to the corneal epithelium that blocks the entry to the tight junctions in the retinal pigment epithelium that refuses the passage. Each obstacle ensures only the fittest molecule gets into it. And we know that these are not the enemies, they are the guardians of our vision. But yet to treat a blinding disease effectively, we should outsmart these local guardians without compromising their natural role. So as we are specialists, most of the time we feel like if there is something to reduce the systemic side effects of the steroids, that will be a blessing to the patient as well as the doctor. And most of the patient will be poorly compliant to the drugs. Why? Because it has more frequent dosing compared to other diseases. And if you are applying a topical drug, it has a very poor or less posterior penetration, as well as its bioavailability typically falls below 5%, necessitating multiple daily doses to sustain minimal therapeutic levels. So considering this existing scenario, we just incorporated nanotechnology for the development of a novel drug delivery system for the non-infectious uveitis. So you're thinking like I'm talking about a science fiction dream or the future of eye care. Let me tell you that I'm not talking about a fiction dream. Why I'm obsessed with these tiny particles? Because even though these are very tiny particles, these have a targeted super delivery power. That is, it is mainly targeted for the inflamed retina or the choroid or the ciliary body, so that it will maintain the sustained release at the particular site with increased bioavailability. Because of the sustained release, it reduces the frequent dosing, so the side effects also. So coming to the nanomedicine, the next frontier in the uveitis therapy. So what happens in the nanomedicine? I will tell you. There are specific nanocarriers for the delivery of some therapeutic molecules. For uvea specialists, we are interested in corticosteroids, biologicals, or immunosuppressants. So we are incorporating these molecules into the nanocarriers. How? There are different types of nanocarriers. I will give you the first example. This is a liposome, which is made up of lipid. So here you can see a central aqueous core which is surrounded by a bilipid layer. What happens is the central aqueous core will capture the hydrophilic molecule, whereas the bilipid layer will encapsulate the hydrophobic molecule. And it has a structure similar to the cell membrane, so it will help in the increase in the permeation of the tissue. So the another one is the neosome. Here you can see the similar structure as that of the liposome, but this one is made up of phospholipids. And what happens is this is more stable than compared to the liposomes. Or you can see some self-assembled nanomicelles. This is most widely used in nanomedicine. Why? Because it has a less cost of production and less maintenance. This is another nanocarrier, that is a dendrimer, which is a three-dimensional structure which is more branched network, and compared to other thing, it has a similar property as that of the protein. Or the last one, you can use a nanoparticle. This is most commonly used a nanocarrier in the development of the nanomedicine in uveitis. So we are thinking about how all this going to happen. Here we are using specific nanocarriers, and these nanocarriers get loaded with either corticosteroids or immunosuppressants or biological, and how they travel. That I'm going to tell you. This is a very complex process, but for the time being, I'm just concising the important things. So the first thing, this has to be adhere, penetrate, and sustain. We are using specific nanocarriers that get loaded with this corticosteroids, immunological, and other things. They will get coated onto the ocular surface. Why? Because these have some mucopolysaccharide like things, either chitosan or hyaluronic acid. This will help on the permeation, or this will helps the nanocarriers get loaded on the ocular surface. And most of these nanocarriers have a positive charge, and the surface mucin has a negative charge. So what happens? The positive will attract. And so what happens is this causes increased retention time on the surface mucosa. After the adherence, then the next step happens, that is it penetrates the ocular barriers either via the transcytosis process or via the endocytosis process. So here comes the play. If you are using a nanocarrier which is size of 50 nanometer to 100 nanometer, what happens is this will evenly get distributed in the vitreous. But if you are using a size of 50 nanometer, that will crosses the retinal pigment epithelium and gets loaded on the retina. And if you are using less than 50 nanometer, that will easily excreted through the choroidal circulation, lymphatic circulation, or systemic circulation. So we are preferring a size of 50 to 400 nanometer nanocarriers for the optimal delivery of the drug to the specific tissue that is our point of interest, either retina, ciliary body, or choroid. Here they are giving a controlled release at the uveal tissue so that it maintains for a longer time and we can avoid the frequent dosing. So the prolonged targeting and the prolonged efficacy is the key role. That is, we are giving a passive targeting and active ligand binding. So I was just discussing about the theoretical aspect. Let me discuss you the road we traveled so far, that is the clinical aspect. And we have shown that the sustained release nanosteroid formulation show long-term inflammation control in the experimental uveitis. Yes, you heard it right. We are still in the preclinical model. This we are using in the rabbit's eyes and the mice eyes to deliver control the intraocular inflammation in the experimental uveitis cases. So what happens is we are using some smarter carriers with smarter steroids. The scientists have such a developed drugs, that is triamcinolone acetonide liposomes, dexamethasone or fluorosilane coated polymeric nanoparticles, and the prednisolone acetate nanoemulsion and micelles. Please consider this is mainly in the preclinical era. And what they have shown, that they showed a sustained intraocular release with a long-term inflammation control with a single injection and non-invasive topical potential. So after having the success of steroids in with this nanocarriers, they just came to the next step, that is the precision immunosuppression through the nanocarriers. What they have developed is there are cyclosporin A nanocarriers. We know that this cyclosporin A nanocarriers is not commonly used in our practice, uveitis practice, but in experimental models, they showed a marked reduction in the uveitis severity with a sustained release and good ocular tolerance. Then other thing they have developed is rapamycin and its derivatives, which also showed a high retinal choroidal drug concentration with a prolonged release, and tacrolimus also. And the third one, that is the delivery of the biological agents. Here, this is the flowchart, that is the infliximab liposome so much developed, and they showed a significant diminished intraocular inflammation, and adalimumab coated hydrogel eye drops also, that also showed a controlled release, which shows an increased permeation and enhanced drug loading efficacy. So you are thinking like, why we are still in the preclinical era, why we are not going to the next level? If ocular barriers are not the hurdle for the nanocarriers, we already discussed. So what limits it's the further thing. So I will tell you the three things that is most important in case of a nanocarrier, that is stability, sterility, and shelf life constraints. Why? Because you are making a nanomolecule which is 1 billion the size of an actual molecule, and for if you are making it in a mass production or if you are in a bulk amount, what happens is everything matters. The size, charge, shape, everything matters. So if you are making it in a good manufacturing practice, you have to make sure all these controlling things are very well established. So this is the main concern about our things. That is, we can't make it in a mass production. But in our era, that is in the 2025, that is not a Herculean task. We can make it in the next level, that is the clinical era. So where we are and what is next, it has shown that there is a proven promises in the preclinical models that I already discussed. We have developed this nanocarriers for the sustained release of the intraocular inflammation control in the preclinical era. And we are expecting a smarter, safer, longer lasting and more effective control of ocular inflammation with fewer injections and better patient quality of life. Why? Because we have already developed nanocarrier associated molecules for other drug delivery system, that is anterior segment diseases, especially like a dry eye disease and other things. So I think this is not, the future is not so far in case of uveitis. There we can give promises to the patients that we are giving a nanomedicine so that they don't need to adhere to the strict timing of the steroids or the frequent dosing of the drugs. They don't need to give it in a, they don't need to get bothered about the serious side effects that is going to happen. So thank you. Looking forward to the future of nanomedicine in uveitis.
Thank you, Dr. Femina. Can we have the first comment from Dr. Chawla, sir?
Thank you. Again, thank you for a nice talk. Again, a topic which is frontier for new research in future. And you have nicely introduced the topic. And for next gen, you have told what are the basics of nanoparticles and what are the limitations of using these particles and what are the possible uses of these particles. So I think you have very nicely summarized the entire topic. And for the new generation, it is definitely what they can look up to and think of as a research topic, and something from which they can learn and design things in future. So a promising area of drug delivery, and you nicely explained it. Thank you.
Thank you, sir. Professor Gupta, sir.
Yeah, that Famina, I was actually looking forward to hearing about how you or your center has been working on developing nanomolecules and nanotechnologies for delivering in specifically in uveitis patients. And what I found, and I may be totally wrong, is, and if it were so, you could have told us right in the beginning that I'm going to give you a review of the nanomolecule or nanomolecular medicine. Having said that, coming to the content, I mean, you showed a lot of those very nice looking cartoons. And I think if you had organized your material in a way, uh, because when you were showing those cartoons, I didn't know whether you were they were given as a posterior subtenon or because you were showing all of them concentrated in the posterior part of the eye in the vitreous cavity and not going through the anterior route. So, having said that, if you had shown us a simple graphics to show the barriers, the penetration as from the corneal barrier to the the vitreous barrier, the RPE, the retinal layer, the various layers like the internal limiting membrane or the the various layers of retina into the RPE and into the choroid where you want to, which is the target. So many a times our target is retina, other times it's ciliary body, other times it is iris or the vitreous cavity. So you could have told us where you wish to target these drug molecules and how compared to the existing technology. Like, for instance, I'll give you an example of toxoplasma. When we treat toxoplasma retinochoroiditis with oral treatment, we give something like 1,200 milligram of clindamycin every day for maybe 6 weeks, and you can calculate 50 grams of it goes. Whereas if we give 1 milligram for 5 or 4 injections that are required, so there's a tremendous scaling down of the dose that we deliver directly into the eye, and that could further be scaled down to nanomolecules when you are saying. So how do they cross the epithelial barrier? Is it intercellular or transcellular penetration? And how they go across these various layers, the lipid layer, the aqueous layer of the cornea, how they flow posteriorly into and they kind of negotiate or navigate through the various layers of the retina, and how long they stay there, what makes them stay, say, at the target tissue in the choroid, why they will not simply flow out. You did mention very briefly about that aspect in your presentation, that they'll go quickly out of the choroid and go into the, how do you make them stick to the target cells like the lymphocytes or T lymphocytes or B lymphocytes or other inflammatory cells, or how do they target the cytokines and neutralize them, or on the soluble as well as the ones which are on the cell surface of all these various inflammatory cells. So there are so many aspects which you could have covered to convince about the forthcoming nanotechnology in the field of ophthalmology, or specifically in uveitis, where we are loading these patients with disastrous doses. And of course, you need to mention about that we can target nanomolecules only in which are local components of uveitis, not the number of uveitis have substantial systemic associations, there where it will not really work that well by giving local injections. But overall, introducing a new concept, it's a fantastic presentation, I would say. Thank you.
Thank you, sir. Comments from Professor Neri?
Yeah, first of all, I want to prize the courage because, and I tell you why. Talking about pharmacology is never easy. When you present a device or a delivery system, we're going to talk about business. So I worked for 15 years as CHMP, so Commissioner for Human Medicine Product for European Medicine Agency. And when you present a drug delivery system, there should be certainly a repercussion for investors that wants to pitch your startup and then give you the line of credit to make it real. And the point is that in the presentation, and I'm talking about, just business perspective, great the potential future. But one thing that is extremely important is, would you inject only intravitally? Is there any space for suprachoroidal space delivery? How much is the toxicity? Which kind of model of toxicity you used? Why did you choose, rats instead of rabbits? So there are multiple different aspects from the research standpoint and the translation to the real life that I would have tackled. How much this can be, let's say, matching other kind of potential future perspectives. Which kind of subset of uveitis would you like to treat with this drug delivery system? How many administrations you forecast per patient? Is it just one shot, 2 shots, 3 shots, multiple shots, PRN? The point is that the presentation is great, but given the fact that you're a scientist and in the future you have to convince investors to put money out of your idea, you need to convince that this idea is sustainable, translated to the real practice is going to become a truth. And then which kind of drugs would you like to see? Because you can tell me steroids, right? But what does it mean? Because we have, for example, Ozurdex. So how much is different? And I wish to remind you one thing. There was a micronized triamcinolone that was introduced in a market in Italy that in the animal model worked very well. So they were patented and then was retracted from the market for the enormous amount of side effects. And those are things that you need to forecast. How much is the risk and how much you would like to offset it? So those are aspects. Since this is a forum that is leaning also opportunities for improvement that I would like to see next time.
Thank you, Professor Neri. Is Dr. Reena there? No, I think she's not keeping well. So we are at the end of the webinar, and this has been a fantastic one. I'm sure all of us have learned so much. I would like to thank all the presenters for making such excellent presentations and giving so much of their time and efforts. We are very grateful to all the panelists for their time and efforts in sharing their knowledge, not only in clinical practice, but also on the art of presentation. I would just like to summarize a few key points that were discussed. So if you have a large topic to cover, please put only the key points in your presentation and do not try to include everything you know. If the time is 10 minutes, time yourself for 7 minutes. If the topic is complex, you have to introduce the basics to a naive audience. Please target the last man in the audience. So I'm just summarizing the points given by our experts. MNB is a more accepted terminology in case of inflammatory CNVM. And there was a very good discussion on this topic, and you should also speak about the toxoscars, the TB uveitis, and the PIC lesions, and the location that is peripapillary in VKH. When you're talking about sarcoidosis, always match the cases with the international diagnostic criteria. FFA is an important tool for follow-up. And there were so many important points that were discussed, but these are the few that I could take down. And there are many for my own reference as well. I thank again to all of the panelists, the judges, and the participants. And now over to Dr. Partho Pratim for the concluding remarks.
Yeah, thanks, Abhilasha. You are such an amazing moderator. I think the NextGen initiative by the Uveitis Society of India, perhaps the first real attempt by any scientific body to mentor and discuss the art and science of clinical presentation with the help of this esteemed panelist. It has actually truly been eye-opener. We were fascinated both by the topics and by the passion and clarity of the speakers. On behalf of Uveitis Society, our president, Dr. Padmavalini Mahendra Das, I sincerely thank all the participants and audience for making this program such a great success. A special note of gratitude to our judges, Professor Amod Gupta, Professor Neri, Professor Rohan Chawla, Dr. Reena, for their valuable time and their thoughtful comments and excellent tips they have shared. I'm sure my next presentation will be slightly different because I have learned a lot. And these insights were not just for the participant, I believe, and truly for every speaker and listener present today. We'll keep this video online in YouTube and we'll try to encourage people to see and learn how they can improve and actually excel in their presentations. With judges, kindly fill the electronic score sheet, which will come to us. And we would like to have you again with us on 23rd Sunday. And personally, I must say it's a really honor for us to have you all here. And before I close, a heartfelt thanks to Mr. Sunil from ZeduTech, who is not only a dear friend, but also an outstanding event organizer who made us to stream this program live in YouTube and Facebook page of the Uveitis Society of India. That's all for today. Thank you once again and have a wonderful day ahead.
Partho,
you
I
so
just want
much.
to make one last comment. I didn't apologize to the participants. I think they have presented all of them very nicely. Needs a lot of courage to participate in a competitive section, and they have done very well. I would say if I sounded harsh, I was not being judgmental. I can assure you, because I have taught, as Dr. Neri said, generation of students. Sometimes I tend to get carried away by my approach, but then somebody has to tell you to go ahead in life. Otherwise, you will keep repeating the same mistakes again and again. And I'm sorry if I hurt anybody. It was unintentional, and it was said on the spur of the moment without any malice towards anyone. Thank you for the opportunity to participate.
This was the actually attempt for so that they can actually muster the skill of PowerPoint. And we need people like you, Professor Neri, Professor Rohan, who will come and tell what was wrong and how they can improve it.
Yeah.
Thank you, sir.
Absolutely. Thank you.
Can I very quickly say something myself? I mean, sometimes when you're asked to spend your Sunday morning and doing science, sometimes you can tell, oh well, I'm grabbing from my family. I can tell you, it was a very good time to me. I'm very honored to have been part of it. I wish to deliver a message to the next generation. There is no right, no wrong. There is just room for improvement. I want to congratulate everyone for the courage. And I can tell you that we are not better than you. Well, I can tell you I'm just older than you. And I made so many mistakes. And the art of teaching to improve, it's only based on the purpose by the seniors to avoid you to do the same mistake we made. And that's what I wanted to deliver today. So I congratulate everyone. Your future is brilliant and the future is yours. And I hope to see you very soon in other platforms. So thank you very much for the great experience.
Yeah, thank you so much. Thank you. This was a
Thank
great,
you so
great
much.
learning
Thank you,
experience
everyone.
also for all of
Yeah,
us.
it was a great
Thank you.
learning experience for all of us. Thank you.
Thank you.
Thank you. Bye-bye. Have a nice
Thank
Sunday.
you.
Yeah.
Thank you.
Happy Sunday to you all too. Bye-bye.